Hello, good morning. Good morning or good evening, depending on where you are in the world. My name's Mohammed Masood. I'm the program director at the orthodontic program at Harvard. And usually around this time every year, we have we invite a graduation speaker. And this year was particularly challenging, but we all worked hard to try to make it happen. I want to thank Dr. Mushiri for being so flexible and agreeing to have this, to continue with the as planned and have this webinar happen. Today, we are, is the first day of a two-day webinar. It's titled Contemporary Clear Aligner Principles with Dr. Maziar Mushiri. Dr. Mushiri is an Invisalign elite provider at his private practice in St. Louis, Missouri. He's a featured speaker in Ask Expert webinars, and he's a lead educator for Class 2 and Deep Bite Solutions. He's an assistant professor, clinical professor at St. Louis University Center for Advanced Dental Education. Dr. Mushiri lectures and provides clinical oversight on Invisalign treatment. He's a diplomate of the American Board of Orthodontics and fellow of the American College of Dentists. He's a paid consultant for Invisalign technology, as well as a serving board member for AIF. Today's session is going to involve 3 lectures. The first one's going to be about biomechanics, then we've got one about Class 2s and one about Class 3s. After each of the lectures, we'll have a Q&A session. So please share your questions through the question box, and after the end of each talk, we'll have a chance to ask Dr. Mushiri some questions. So without further ado, I'd like to give the podium to Dr. Mushiri.
Thank you so much, Doctor. Appreciate it. And thank you everyone for being here today. I was certainly looking forward to seeing you all in person, but this will have to do for now. And I'll cheers to the day that we can see each other in person again. So again, thank you for the introduction. Just as a brief personal background, this is my lovely wife, Michelle, and my son, Shia and Sadira. If anything, you know, it may be cliche to this point in terms of silver linings, but having been able to spend more time with them has been amazing. And I have gone back to work this week. On Monday, we started seeing patients again, albeit in a completely different context, as you can imagine, which has its challenges, but it's also been very rewarding. I totally just didn't realize how much I loved putting braces on teeth or engaging with my patients and delivering their aligners. It's been amazing to start serving them again. So I hope that you all, wherever you are in the world, will be able to start doing that soon if you have not already. Our goal, of course, of the next couple days is to discuss clear aligners and Invisalign. And you know, it's been an amazing learning curve and journey for me using the appliance. I joined my father about 12 years ago in orthodontic practice, and we were not doing any clear aligners when I joined him. And that kind of started the path because we saw an opportunity there to help people with clear aligners. And I'll kind of give you some background as we talk through the day about what I mean by that statement. But my journey is taking me to where we are today, and I still learn something about clear aligners every day. It's, you know, we never stop learning, but it's been a great adjunct. So I hope to give you some of the pearls that I've learned over the years here. So why clear aligners, first of all? When we discuss anything in orthodontics, the why, I think, is important in terms of modality. I know that at Harvard, I believe 35% of the patients are being treated in clear aligners. So that's what I consider to be a very progressive program, because not every university is really along that trend. If anything, many are lagging behind. So number one, they're effective at treating malocclusions. We don't want to do anything that's not effective. And so I think over time, given the advances that Invisalign has made, or given the input that doctors have given, the appliance has improved. It's improved greatly to where we're treating almost every single malocclusion, honestly, with clear aligners or Invisalign with the same confidence and expecting the same outcomes as we would have fixed. Now, there's exceptions to that statement, of course, and we're going to cover those today. But for the most part, the majority of malocclusions we're able to treat with clear aligners. Certain cases treat better, certain cases treat worse. But what cases treat better? Really high angle cases. High angle cases, or patients that are hyperdivergent or that have an open bite tendency, I really would prefer to put those type of patients in aligners personally. I think the side effects of treating patients in fixed appliances can cause really bite opening that we have to fight and manage throughout the duration of treatment. And that's not very efficient. So you put an aligner in someone's mouth, day one, you can start closing the bite. So that's very effective. More kinds of periodontium, of course. We have lower forces, improved oral hygiene, less uncontrolled tipping because of digital treatment planning. So that in and of itself has advantages. Patients, of course, prefer the modality. As I've gone back to work, I can tell you with 100% truth that I've had more patients requesting clear aligners this week than I have had patients requesting braces. So that's a reality when you get out. You don't necessarily want to acquiesce to a patient's wants if you cannot give them a good result, but if you feel like you can, there's going to be a big demand for it. So we have to be prepared for that. Improved clinical efficiency. This is no more true than it is today, honestly, in terms of COVID and what we've been dealing with. I've been going to work every day since we've been shut down, really doing virtual calls from 8 to 3, and intermingled with the virtual calls, having team members there where I will go tell them, please do a curbside delivery for, Mr. Smith and give him a liner, 10 through 30 or whatever, so that he can progress with his treatment. And my patients in clear aligners were progressing the whole time. Even when pre-COVID, we were seeing those patients every 3 to 4 months, much longer intervals than are generally would be seen with fixed appliances. So it's a very clinically efficient appliance and an amazing adjunct to one's practice. The appliance also, in terms of our learning, it's a relatively new appliance in terms of the history of orthodontics. So it's continuing to improve, and it always will, just like braces may improve as we get into the digital really world of 3D printing brackets, for example, and digital treatment planning. Things are always going to improve. So we don't want to discount that. We want to jump on the train. We want to make sure that we're learning with it and that we are becoming specialists in the appliance, because that's ultimately what we are. We're specialists, and we need to differentiate ourselves from those who offer the appliance without really having the proper background to do so. So I think it's important that we give that reason to our patients as to why they need to see us. How has the development process improved over time? So for one, when you look at the aligner, we can have altered geometries of the aligner, which essentially elicit a force system. And with Invisalign, you can have power ridges, you can have these pressure areas that we'll review. You may also hear them referred to as activations of the aligner, but essentially these deflections of the aligner can elicit a force that will cause the tooth to move, of course. And that's one way that we can continue to improve the efficacy of the system as a whole. Another way we can do that are with attachments. And the way I like to refer to these, because I'm hoping that it forces you to think in a certain way, is that when you add an attachment to a tooth, what you're essentially doing is that you're changing that tooth's anatomy. And that's how I like to think about it. I want to change the anatomy of that tooth to provide it with an undercut so that the plastic can not only push that tooth in the desired direction of where I want it to go, but so that also that tooth stays in the aligner. Retention. Retention is an extremely important concept to grasp when treating and treatment planning with clear aligners, because all teeth in an aligner inherently feel intrusion, inherently, because they're getting squeezed. That's how the appliance applies force to a tooth. It has to squeeze it. It squeezes it from the buccal, it squeezes it from the lingual to get the tooth to move. And teeth are generally, they don't come with undercuts per se, unless it's a crown and bridge issue, right? But most anatomically God-given teeth don't really have proper undercuts. So teeth feel like they want to slip out of an aligner quite readily. And adding an attachment is there just as much as it is to push into a desired direction as it is for retention. So attachments, in my opinion, are paramount to treating moderate to severe cases with success. You have mild cases that you want to treat, with in-house aligners, just tipping here and there, that's not such a big deal. You may not need attachments for that. But once you start getting into comprehensive treatment, you need attachments. Aligner material, this is something, again, that I believe is a big opportunity for improvement. and development in terms of how the appliance will progress in our future. Currently with Invisalign, which is the system I use, SmartTrack is the liner material that's used. They say it's analogous to a NiTi wire, which I would tend to believe. It has a low insertional force in the beginning, long range of force delivery for low continuous forces. And that has its strengths and weaknesses. We obviously use a NiTi wire for a very specific purpose in orthodontics, but when you get to the latter phases of treatment where you need to level a curve of speed, or where you need to develop an arch form, let's say you ascribe to Damon philosophies, where you're going to put an expanded stainless steel wire in to help develop an arch form. That's a material property really issue there at that point of treatment, that you need that stiffness of the material to help level the curve of speed or to help get that arch development. So what happens if you're doing all of that with a NiTi wire? You're going to have to make certain compensations to make that more predictable, or certain exaggerations of how you bend that wire, and how do you bend an aligner, so obviously we're going to talk about those things, but we need to think about all this because this adds up to the success of your outcome. The last really thing I want to focus on today as we get through the talks is staging. So staging is the order of which teeth move in the aligner. And if you look at the animation currently, it's illustrating an extraction case. And historically with premolar extractions, you would see staging via en masse movements, meaning if you extracted the premolar, you would see the 3 to 3 walk back as a segment essentially. So you'd see the 4 to 6, or excuse me, the 5 to 7 and the 3 to 3 coming together like this in the clean check. But clinically, what would happen is that you would get complete dumping of the buccal segment and what we call bowing of the aligner. And why would that happen? Well, it's because you're closing spaces on the NiTi. It overwhelms the aligner and you get bending or bowing of the appliance. And that same thing would happen if you close an extraction space in the 014 NiTi with C-chain. You get dumping and just loss of control. So what happens here is what you're seeing now is that the canine is walking back by itself. And once it's about halfway the distance, then the 2 to 2 starts to retract. So this is called G6 staging with Invisalign generation 6, which is the 6th generational improvement of the appliance. What that's doing is not only is it giving you a full wrap of plastic around the cuspid as it's retracting for better bodily movement, but it's also slowing the movements down because you get many more stages with this. And that allows the aligner to recharge into level the curve of speed. Now, there's other issues with this treatment plan, which, I'm not going to get into the minutiae of it, but I don't necessarily agree with the attachment design here. And we'll get into the reasons for that. These attachments are great for controlling root tip, but they're not great for retention to level of curve of speed, which can become an issue when you're closing this much space, because when you close space orthodontically, the bite deepens, and that's something that we're going to harp on today. So again, Invisalign has had a slew of changes over time, all of which have helped to improve the efficacy of the appliance, but nothing is perfect. Your braces aren't perfect, right? That's why you do pan repos. That's why you make bends. So what are the variables for predictability with an aligner? First off is the patient, and then case selection and psychology. So with regards to the patient in psychology, I can be the best alleged clear aligner orthodontist on the planet, which I'm not, but I'm saying let's just pretend I was. If I have a patient that's not compliant, that doesn't matter one bit. You have to make sure your patient's on board, and that all starts at the consultation, and your patient can humble you very quickly with lack of compliance. So you got to make sure the patient's on board. That means really clear communication, really clear motivation through treatment. And case selection is another thing. Not every case is an Invisalign case, just like in my opinion, not every case is a braces case. We have the appliances have strengths and weaknesses, and as the doctor, as a treating orthodontist, it's up to us to really understand those things and to set ourselves up and the patient up for success. The clean check is the other variable here. The clean check is what you use to bend your aligner. And this is very nuanced. We are doing orthodontics with Invisalign. We're not doing Invisalign. We're doing orthodontics with Invisalign. This involves biomechanics. This involves growth and development. This involves biology. This involves many variables that we need to combine to have a successful outcome. So as you see here, I'm saying a thorough evaluation of the ClinCheck and understanding of the plausibility of situations is very important. We need to be constant students of the appliance. We need to constantly try to improve and learn with this. It doesn't, I don't want us to ever pass blame to a company. If something doesn't work, it's your fault. It's not the company's fault. You're the doctor. So we need to take control of this appliance and make sure we understand it. The sooner you do that, the sooner you go on this journey of learning, you're going to have amazing outcomes for your patients, and you're going to have immense value added to your practice and to your patients' lives, because it's a great appliance, I think, to incorporate. And notice there, that last line there is anchored as grossly undervalued, which again, we're going to discuss today. As I mentioned, we're doing orthodontics, so diagnosis is key. What's the etiology of the malocclusion? Are you diagnosing that? Are you using your Ceph to analyze things? Is there a tooth size discrepancy? Is there growth involved? How are you managing your anchorage with elastics? All of these things will add up in terms of how your outcome is going to turn out. And my team is very important. I was speaking with Mo earlier today before we got on the call about D-bonds actually, and delegating D-bonds to assistants, but we delegate our attachments, our bonding, to our assistants. And certainly if our assistants do not take that indirect bonding process in a detailed fashion in terms of how they approach it, and they don't bond the attachments accurately, we just lost the whole case, because the attachments aren't serving the intention of what they were meant to. So again, there's a lot of variables here, and it takes training and it takes time. But that's why we went to school. That's why we continue to practice every day, and eventually it all comes together. With regards to case selection and aligners, what are the easiest cases to treat? What are the ones you maybe want to stay away from? This is a diagram, it's my opinion, of course, of the easier cases to treat up top and the harder cases to treat at the bottom. And notice I've divided this into thirds. I do this for the purpose of one, if you're just starting out with Invisalign, you want to stay above the line in terms of what you're attempting. And then as you gain confidence, as you've mastered the top four, then move on to the middle. And once you've mastered the middle, then move on to the bottom. I think that sets you up for success, because as you incrementally go down, the cases incrementally get harder. What we also do here in terms of just from a practice management standpoint is that when I'm in the treatment conference with my TC, I tell her that the case is Invisalign 1, 2, or 3. 1, 2, or 3. And that tells her how much to charge. Because the harder the Invisalign case, the more I'm going to charge, for two reasons. One, it's more expertise involved. It's more of a niche treatment. Two, it may take more treatment time. So we don't charge the same fee for every patient that walks in the door. And I would encourage you to maybe consider that. Because again, you have a lab fee to consider, but I don't think that's the biggest variable that should come into play of how you make your diagnosis and considerations for patients, because there's other advantages, as I've mentioned, to delivering clear aligners. But you should charge for your expertise, and you should charge for the time spent, without a doubt. So as you go through this list, I think you want to consider that. The one at the bottom here, which I think is important to consider, is that the hardest cases to treat with Invisalign do not necessarily matter on the classification of the patient, meaning class 1 or class 2, but rather on the depth of the bite. Patients that have a very deep overbite, where you cannot procline the dentition, meaning that they present with minimal crowding or even spacing, in my opinion, should not be treated with aligners alone. You may need a hybrid treatment on them, meaning braces on the lower arch and Invisalign on the top. Or if you can set the case up for restorative, meaning to procline and open spaces for the teeth, that will make that case more successful overall. So I don't want anyone to get into trouble or get caught on a case where they shouldn't have really treated that case with aligners only. So now that we've kind of established a baseline for certain things, what I also want to discuss today are biomechanics. And we're going to get into treating and talking about rather a lot of different types of malocclusions, but I want to establish at least a baseline of fundamental biomechanics, because that'll help you to decipher how I've set up my ClinChecks. And just in terms of a little bit of housekeeping, if you will, I'm going to go straight through, meaning for the next 3 hours, I'm going to just talk. But we will take breaks for questions at the end of the section. So the first section is biomechanics. Then we're going to discuss class 2, and then we're going to finish with class 3 today. So we will take some questions, but I'm going to go straight through because we have a lot of content to go through, but I wanted to give you an overview of what to expect today. So when we discuss the differences between aligners and braces, you know, as I mentioned, it's all biomechanics, meaning that there's a lot of similarities, but there are some differences. And the main one is that when you think about how appliances work, braces apply a pulling force generally from the labial. You know, obviously we have lingual braces, but the majority of braces that we use are from the labial. And this usually follows a sequence of wires that we need to use to level and align and to work up into a heavier wire, of course, usually a round night tie to a rectangular night tie to a rectangular TMA or stainless steel. We all have different ways of how we approach this. It's a very complicated system because there's a lot of equal and opposite forces occurring during the whole leveling process, assuming continuous mechanics. So it's nearly impossible to really measure what's going on in the whole system simply because of, again, all the equal and opposite forces that are occurring. With aligners, of course, we apply a pushing force on the crown more selectively in certain areas based on the deformation of the plastic and where it's applying more pressure. Follows a sequence of progressive alignment within a series of aligners. The change in the shape of the aligner is what causes the tooth movement. So it's a change in the shape of the aligner that elicits a force to cause the tooth movement, moving the tooth eventually into the desired direction. We are better able to accurately measure the force systems on an aligner, generally speaking, because you don't have a lot of continuous movement occurring at once. If you wish, you can have a group of teeth moving here, a group of teeth moving there, based on what your overall goals are. However, irregardless of that fact, there are unintended consequences of tooth movement still that the practitioner needs to consider that affect the overall attachment design. So what I mean by that is, and this is an important concept to capture, and this is probably the thing that gets us into the most trouble, I think, is that the ClinCheck is a representation of a force system, not only a result, meaning that we usually depend on the ClinCheck to give us a prediction of what the final outcome is going to be, but we trust it too much. The final result of the ClinCheck will generally fall short of what you expect in terms of what's going to happen clinically, based on the movements that are occurring. And some movements have certain consequences that we really need to consider, because if you don't do that, you're going to get into trouble in terms of the outcome. So we're going to highlight those, of course, today. So in general, again, aligners apply pushing force and braces pull. If you think like braces, you're going to end up not being able to open the door. So we need to make sure that we differentiate the thought process that, again, aligners push, braces pull. This has a different biomechanical approach in terms of how you're designing things. Because again, for example, if I think I'm going to extrude a central incisor and I'm going to pull that tooth down the long axis, and you try to design your attachments to do such, you're going to have failures. So we'll discuss, again, how to push a tooth to extrude versus how to pull a tooth to extrude. Because if you try to do one versus the other, you'll have different outcomes. As we discuss biomechanics, again, as I mentioned, we push. So to push, you need attachments. With Invisalign, you get optimized attachments, which are made by the software. The software automatically creates these for you using quote unquote artificial intelligence to basically guess for you what is the most important attachment that tooth needs to have a successful outcome. Teeth generally have a menu of attachments of what they can get. So for example, a canine can have a rotational attachment. It can have an extrusive attachment. It can have a root control attachment. So there's various attachments that cuspid can get. So the software decides what's the most important movement. I see more rotation, so I'm going to make sure I give this tooth a rotational attachment. The push surface of that attachment is at a certain angle. So when you bond that attachment using the attachment template, that attachment is at a certain angle. However, the aligner engages that tooth at a different angle. The difference of those two angles is called the activation angle. And Align touts this as pre-activation, meaning that that difference in how the aligner will engage that surface builds in a level of predictability into the system. So if that attachment breaks, for example, and I go ahead and I just use the patient's aligner they walked in with to fix it, I'm losing a large advantage of the system. So if ever an optimized attachment is broken, you want to use the original attachment template, cut that tooth out individually and use that to repair the attachment. Or as an alternative, you could call Invisalign and say, hey, this patient broke their attachment at aligner 18. Please send me a number 18 aligner template, because that way, obviously, the teeth have moved and the original template won't fit. That way, you can have one that does fit. Optimized attachments are, again, automatically placed by the software. I have here no modifications can be made to the position, which is true. However, you can modify the size of them now. So in your doctor preferences, there has recently been, by recently I mean within the last year, you can have a preference where you select, please give me the largest possible optimized attachment for anterior teeth. Please give me the largest possible optimized attachment for posterior teeth. I, of course, have selected give me the largest, because when you push something, surface area is king. And I want to make sure that I have as much surface area possible when I'm pushing something to have an effective relief force system. As I mentioned again, this is something that is on Invisalign's website. Please study this. It's important to know what attachments exist for what teeth, when and why are they triggered, because then it's up to you as the treating doctor to understand, is this attachment appropriate for this patient's situation? Should I maybe even request a different type of optimized attachment because I know the menu of what exists for this tooth and I actually think this is more important, even though the artificial intelligence told me this one's more important? Because ultimately, again, you're the doctor, you know what's best. So again, just not to belabor the point, there's many attachments available. I would please reference these for future learning. With regards to conventional attachments, of course, these are attachments we can place. We can customize them. We can change the shape. We can change the position. We can change the size. The reason why I would consider using conventional attachments are for when conditions and thresholds are not met for an optimized attachment to be placed. So for example, let's say that I have a lateral incisor that has 10 degrees of rotation. That's pretty substantial. But for whatever reason, in the software, the conditions and thresholds were not met for that tooth to get an attachment, which happens. It could be because of the root anatomy of the tooth or how the software predicted, again, the root anatomy was that it didn't properly catch the movement. Again, that happens because at the moment we don't merge CBCT with our scans. So there's guesses that are being made or predictions. So that's the time when I would add optimized. Or there are certain situations where simply an optimized attachment doesn't exist. So for example, if I have a molar that has root tip, there's no such thing as a root tip attachment for a molar in the software. What if I have a lower incisor that has root tip? Quite often we have lower incisors that may need to have distal root tip built in because of crowding. Well, again, there's no root tip attachment for a lower incisor. So there's certain circumstances where you need to add an attachment just simply because it doesn't exist. So let's talk about movements. Tipping. Of course, tipping is one of the easier movements in orthodontics. With fixed appliances, there's potentially a negative consequence to tipping, and that's uncontrolled tipping, where you have the crown and the root moving in opposite directions. This is generally unfavorable. It's generally viewed as an unstable movement. It's generally viewed as one that's not kind to the periodontium in the presence of crowding, for example. So it's one movement that we want to try to control. And that simply is because we're pulling from a labial position, labial to the center of resistance, which tends to pull the crown more anteriorly or labially. With aligners, you don't have as much of that uncontrolled tipping. And if anything, you actually have controlled tipping. Why is that? Because you have thousands of points of contact labially and lingually on the tooth. So when I think about an aligner, I said it's very similar to a nai-tai. What kind of a nai-tai? I think it's similar to a rectangular nai-tai because I can control torque day one. And that is a nice advantage, again, of Invisalign or of treating with aligners is that in a case, for example, where I do not want or I really wish to avoid uncontrolled tipping, where there's an increased IMPA or where there's periodontal problems, I can elicit that control day one with the aligner. But as I mentioned, there's certain consequences to tooth movement that we need to be very cautious of because they can lead to problems clinically. And one of those consequences has to do with tipping. When you procline a tooth, so if you look at the diagram of the incisor now, and let's say I'm going to push that incisor labially. If I push that incisor labially and we have tipping, what ends up happening is that the incisal edge will want to intrude if the center of rotation is close to the apex, which generally it is pretty close to there with an aligner. So if I'm tipping an incisor labially and the incisal edge intrudes, that's really favorable for a deep bite malocclusion, because as I procline, the teeth naturally, as a side effect of the movement, want to intrude. But let's say I have a deep bite malocclusion and I'm actually retracting the dentition. Well, now the teeth want to extrude, and that's a clinical consequence of the movement. So what's going to end up happening is that if you have generalized space closure and the ClinCheck is showing that your bite ends up ideally, what's going to end up happening clinically is that you're going to finish deeper than what you anticipated, because the ClinCheck cannot predict, and it doesn't do a good job of it, of predicting the clinical consequence or the resultant movement that occurs when you have certain types of tipping. So we have to take that into account as an orthodontist, and we have to over-treat for that. And we're going to talk about that a lot today. So again, if I have a deep bite with a steep curve of SPE, my desire would be to procline as much as possible, which this patient, we were able to do that with. And again, I'm just talking through things. We'll go through comprehensive cases later, but let's assume that this patient had upright lower incisors and the IMPA that I could afford to make more, again, obtuse. So favorable periodontium, we can flare the incisors. Those are favorable, really, considerations for a deep bite, and those are great deep bites to try to treat with an aligner. As we go through here, and again, talk about more movements here, case in point, this is a deep bite that if you look here at spacing. So in order to close the deep bite in this case, we are closing the upper space and intruding. We are closing the lower spaces, and actually there's some IPR in this case because of the Bolton, and intruding, and finishing to where you see here on the lower right side of the screen for you. So you can see that we're finishing with an ideal overbite. Clinically, this patient finishes much deeper than the actual prediction. But not only that, I would argue that you finish deeper than when they even started. That rarely will ever happen to you in braces. It's actually quite a surprise when it does happen to you in aligners, because again, we're not used to that. You rarely have cases with fixed appliances we put braces on, and the case finishes deeper unless you're extracting teeth and you have mechanics that are unfavorable. You don't get surprised by it, is what I'm saying. So, this is again a consequence of the space closure of this case. Space closure on the upper, space closure on the lower, again, leading to a clinical side effect of bite deepening, which certainly was not the intent for this patient. We wanted to finish more open overall. When we talk about intrusions, we were talking about tipping before. We'll talk about intrusion, of course, with braces. We can do intrusion arches. You can do a step bend in the wire. This is probably actually one of the few examples of when braces or a wire pushes. You put that step bend in there. It's actually pushing the central incisors up. There's a reciprocal and opposite force pushing down on the lateral incisors. So certainly you need anchorage here with regards to the adjacent lateral incisors to make the centrals move. You probably, of course, need the cuspids and the premolars as well to make that more of a predictable type of movement. So anchorage is an important consideration here with this intrusion overall. And the same applies to an aligner. So remember what I said, what causes a tooth to move? What causes a tooth to move is a change in the shape of the aligner. So if we try to visualize this case where the dentist is coming to you and they say, "Doc, I need you to intrude the upper left one." because I'm going to lengthen that crown restoratively. So please go ahead. This patient really wants Invisalign. So let's go ahead and do that, and then we'll reconvene and see how far we got. So you're setting the case up on ClinCheck, and you're thinking to yourself, well, if I'm going to intrude this upper left one, the change in the shape of the aligner is going to look like this. So when the patient goes to push that aligner in, what is going to be the equal and opposite force adjacent to that tooth? Well, it's going to be for extrusion. So if you do not have attachments on the adjacent teeth, you will have a failure of the intrusion of the upper left one. Furthermore, your patient is going to be upset. Why are they going to be upset? Because their aligners are going to be sagging off of the upper right one and the upper left two, for the entirety of treatment. Because these two teeth are not failing in their movement, which is what you may think they're failing in, but they're failing in their anchorage. So if we do not apply these attachments, not only does the movement fail, but the patient has a saggy aligner. And everyone hates a saggy aligner, especially in the front dentition, because that's the aesthetic zone, and that's where they start lisping because the teeth are, those plastic is coming off the teeth. So that's a very important consideration, because you'll have patients come in that will tell you, or will ask you, say, I really want Invisalign, but I don't want to attach it to my front teeth. And then I say, well, I'm happy to give you Invisalign, but if you don't want attachments to your front teeth, I'm not going to move them. If you want movement of the front teeth, we need attachments. They go hand in hand, because anchorage is necessary for the movements to occur, especially depending on what movements there are. So again, when you set up the right force system, you can get the right result. When you talk about more generalized intrusion, and we're going to really discuss this in detail tomorrow, we start talking about tomorrow's deep bite, open bite, and orthodontic surgery. So with general intrusion, Invisalign has improved the appliance over time, because intrusion, I'd still say, is one of the weaknesses of an aligner. You can get it, but you have to really understand it, meaning that it's not for the faint of heart. You want to really, I think, dial it in and have some interesting looking ClinChecks with regards to how you bend your aligner. And we're, of course, again, going to dive into that. But what Invisalign realized on the bench is that when they were analyzing the force system for intrusion, the sum of these vectors that you're seeing around the clinical crown of the lower incisor, the addition of these should really equal a resultant vector that is going down the long axis of the tooth. So right down the long axis of the root to get effective intrusion, when in reality, what they realized on the bench was that the sum of these vectors was going off at a 45-degree angle. So that is obviously not an efficient force system for intrusion. So Invisalign now, when they detect a movement of greater than 0.5 millimeter of intrusion for the upper or lower 3 to 3, so the upper or lower 3 to 3, a pressure area or activation is automatically placed in the lingual of those anterior teeth. And that creates a resultant force now that does go down the long axis of the tooth. And this has definitely created more effective intrusion with the appliance. I got a message here that there may be some cutting in and out of my voice, so I apologize for that. If that continues, let me know, and I can try to make some adjustments here with my internet as needed, but just continue to please keep me abreast of that development. Also, in terms of some enhancements with Invisalign, what we've noticed here in terms of attachments is that G5, which was the 5th generation of improvements, for intrusion, of course, there's a reciprocal extrusive force. And in order to capture that force, you need to have attachments. So we have what are called G5 attachments on the premolars. But that is, in my opinion, truly inadequate, because when you have a curve of Spee that you're trying to level, if you imagine a reverse curve of Spee wire that you would bend to the lower arch, you could imagine that there's a lot of extrusive force on the molar. So you need to have a retentive attachment there. You could imagine in a situation like this also, where the incisors are more incisal than the canine. These teeth need more intrusion than the cuspid does. So there is a reciprocal force that's needed on the canines as well. So in my opinion, for effective leveling of a curve of spee, you also need to add attachments to the canines and to the first molars, which is not a solution that we automatically get with Invisalign, because you have to capture the extrusive force on the molar and the extrusive force on the cuspid, which occurs from the bending of the reverse curve of spee and intrusion of the lower incisors past the incisor position of the cuspids. When we talk about rotations, so again, we're going through each movement, and this is all in an effort to understand how the ClinChecks will be designed. Complicated rotations like the one you see here, braces are going to win every time. It's too good of a force system. The wire is engaging the bracket very intimately. The only really position this tooth has, the only choice it has, is to derotate. With an aligner, again, because aligners push, that's going to be more challenging. You know, when we have a minor rotation like this, you simply go to engage the wire into the bracket. That creates a moment, and that moment derotates the tooth. It's a very nice force system. So I want you to know that, because we need to be honest, right? You don't want to get into trouble. If you have significant premolar rotations, if you have significant cuspid rotations potentially, and the patient is adamant about having Invisalign, you may want to do some segmental mechanics to resolve those rotations first, make a same-day Essex, and then put the patient into Invisalign. Because generally speaking, as an example, let's say that you have a premolar that has a 45-degree rotation. Well, rotations resolve at 1 to 2 degrees per aligner. So now you're getting an order of, let's say, 30 to 45 aligners to resolve one rotation, which probably isn't going to look so good when you're done anyways, because it's not very predictable. Well, then you need to have a refinement to address the same difficult movement, when really you could have just knocked that movement out in 6 months with some buttons and elastics to establish a couple. So again, just be honest with yourself. Don't try to be a hero. You want to make things easy on you, easy on the patient, and efficient. And rotations can be challenging with aligners, in my opinion, when they really exceed 20 to 30 degrees is when I start looking into partial mechanics. So when we resolve rotations, you know, we have rotational attachments. And again, there are optimized attachments for these solutions. You also can get activations, so pressure points on the lingual of the aligner, for example, to create a counter moment to, again, help facilitate the rotational correction. Please notice the design of the rotational attachment. I think it's very elegant, and I think it's important to understand. When we have a cuspid, let's say this canine is rotating mesial in. So let's say it's rotating mesial in. I think it's intuitive for us to understand that if we had a vertical attachment here, let's say, that you could push from the distal to the mesial to help that tooth to rotate mesial in. But this attachment is not designed vertically, it's designed obliquely. If you look at the push surface here, the push surface of this tooth is at an oblique. Why is it at an oblique? Because one vector we don't take into consideration enough is retention. And as that tooth is rotating, again, it's feeling intrusion. So the reason why that this attachment's at an oblique is so that there's a surface to push on to also keep the tooth seated in the aligner. So the push surface of any attachment, be it an optimized attachment or a conventional one that you design, should have the push surface designed so it's perpendicular to the sum of the net forces that are acting on the tooth. So the sum of the net forces here are for a mesial in and for extrusion. So the sum of those is at an oblique, so we're now perpendicular to that vector. So please consider that when you design your own attachments, and just understand that that's the way optimized attachments are designed as well. Again, we talked about this, that there's an activation or an activation angle. So if the optimized attachment is broken, you want to make sure you use the original template to rebond it. That's very important. Let's look at this situation. So central incisors do not have attachments for rotation. So if you have a severe rotation of a central incisor, again, we mentioned that what the tooth is feeling in the aligner is this. So if you look at this diagram here, we have the interproximal view of a central incisor. So let's say that there is a mesial in force from the labial, and if we're looking at the upper left one, for example, that there's a mesial in force from the labial and a distal out force from the lingual. Well, if we look at that tooth interproximally, that's the force system that it's feeling. And this tooth is shaped like a triangle. So again, that tooth is feeling intrusion. It's getting squeezed, right? So how do we prevent that from happening? Well, you can see it. We added an attachment to that tooth to keep it seated in the tray so that as opposed to feeling this intrusion, which is still going to feel, we're now giving a surface with a push on for retention to keep that tooth seated during the rotational correction. And if you do that and take those considerations, you're going to have nice movements. So again, retention is key. Extrusion with braces, of course, you put a step bend, you get extrusion. It's very effective, and it happens, routinely for us. We understand these mechanics. So sometimes there's side effects of the movement, of course. So for example, when I'm extruding a tooth, it may want to go to the lingual. So I have to put compensatory bends in there to adjust for that. But the extrusion itself happens fairly predictably. With Invisalign, there's two types of extrusion I want you to think about because they're important that you differentiate them. For one, we can have a resultant extrusion, which I hinted at earlier, which is an extrusion that is a result of a movement. For example, if the tooth is going to the lingual, generally it has a tendency to extrude as it goes to the lingual, so that's a resultant type of extrusion. Versus a pure extrusion is when you're really trying to push that tooth down the line axis. So when we look at this animation, the upper left one is experiencing more of a pure type of extrusion. It is actually moving labially. So as it's moving labially, it has a tendency to intrude. So we are truly now having to push that tooth down the line axis to get the moving one. Versus the upper left two, this tooth is actually moving to the lingual duration of treatment. So because it's moving to the lingual, we can see that that tooth has a natural tendency to extrude. So if I had a choice, if I had to set up my extrusive movements, I would prefer the movements to be set up like you see on the tubes, where both tubes ultimately have more lingual than where they started. That's going to give you more predictable extrusion if you can afford it. How do you do that? You can do that with IPR, you can do that with arch development, you can do that with extractions, of course. But what about the pure movement? Is that unpredictable? Is it going to happen? It happens, but you need to have a patient that's very compliant, and you 100% need to have an attachment on the tooth, because if you don't have that, you're going to have problems. The patient illustrated here was being set up for enamoplasty because they chose not to have restorative. Hello? Chris, you may be unmuted there. Chris? All right. Sorry about that. So as I was saying, this patient...
right now.
Okay. Is everything okay?
Yeah, you're good. I'm going to text Chris.
Thank you. So with regards to the case here, what we ended up doing was enamoplasty for this patient because they did not want to have restorative done. Okay. So that's the patient mid-treatment. Again, showing really that both types of extrusion occurred predictably, but I wanted to show you that as an illustration to differentiate the two different types so you could see that they both can occur. But again, in my opinion, one is more predictable than the other. So we went ahead and did some enamoplasty for this patient to finish the case up. This is where I think an understanding again of the difference of how plastic pushes and braces pull is important. Optimized attachments are my favorite attachments in terms of what Invisalign gives us. I just have kind of a weird obsession with them. I think they work beautifully. and I love how they're designed. I think a lot of thought went into them. And so I want to discuss the details of that. Optimized attachments, of course, are given to you for extrusion when you have greater than 0.5 millimeter of extrusion that is really noticed by the software. And for open bites, they work beautifully. They do have different activations on them, meaning that when the software detects an open bite, the amount of force that is placed on each attachment is customized and different for that patient based on the amount of movement and the tooth's anatomy. But this is where it gets really interesting, in my opinion. And I want you to please pay attention to this because it's really important. Optimized attachments for extrusion have an activation built into them. Basically, this illustration with the blue line is showing a diagram without activation. This one is showing a deflection of the plastic to help engage and push the aligner against the attachment and to push the tooth into the tray, assuming there's a relief, of course, at the incisal edge. But please look at the difference in size labial-lingually and mesiodistally and incisal-gingivally of the attachment versus the well of which it's seated. And you can notice that when the patient goes to put their aligner in, the attachment is actually thicker labial-lingually than the well is for the attachment. So that forces the attachment to push and squeeze against that surface area to force that tooth essentially to the incisal. So we're not pushing down the long axis, we're pushing labial-lingually. We are forcing that tooth against the lingual wall of the aligner, and it's getting squeezed incisally. So that, again, is where we have to differentiate the way we think about the biomechanics, because we're not pushing down the long axis, we're actually pushing the tooth lingually to get extrusion. And notice all the relief around this attachment. There's relief mesiodistally, and there's a lot of relief incisally. So again, if you use the patient's, the aligner they walk in with, you're going to lose all of that relief and you're going to lose the activation. So that's really, again, the beauty of the optimized attachment and the force system that's built into it. And it's a great attachment. It works beautifully for Invisalign patients. Of course, sometimes you have situations where you cannot get an optimized attachment on a tooth, and then you're forced to do extrusion, right? So we use bootstrap mechanics. You can use TADs to pull the tooth away from the root of the lateral, and then use a little helical loop I bent here to pull the tooth into the arch. But, you know, is this fun? I guess it's fun, but it just takes a lot of time. You know, it'd probably be more efficient with braces, honestly, in a case like this. But is it possible? Yes, it's possible, but you certainly should charge for an exercise like this because it's going to take a lot of time and effort on your part. Tipping, when we talk about tipping, and I apologize, I know I'm very heavy on biomechanics, but please understand it's so necessary to the latter discussions of malocclusions. So hang in there with me. We're almost through it. But with regards to tipping, of course, along a wire, you get more of a ratcheting type movement. We generally are pushing or pulling that tooth beneath the center of resistance. So you're going to get tipping. So that tooth tips along the wire to give you more of a bodily type movement. Of course, if you want true bodily movement, you're going to have to use power arms or TADs to get the force through the center of resistance. I think we all understand that with fixed appliances. But the same concept applies to aligners. We're pushing the teeth beneath the center of resistance. So any semblance of root movement or bodily movement we think we're getting is likely going to end up in tipping of the crown. So we need to compensate for that, and we need to adjust for that. So with Invisalign, we do have, for certain teeth, for example, centrals on the upper, canines on the upper and lower, premolars on the upper and lower, these G4, generation 4 root control attachments. And this is basically a glorified vertical attachment, because all I have is an attachment that I'm just pushing like this on. Well, they just took out the middle. Obviously, this is more aesthetic. for them, and Invisalign being an aesthetic appliance, I think has to balance efficacy versus aesthetics and try to marry the two together. So this is the marriage of those two solutions. And you can see this gives us two opposing surfaces to push on to get the moments needed around the root apex for tip. And these solutions are triggered when you have root tip or bodily movement. Again, they exist for various solutions for, again, centrals, canines, premolars. Generally speaking, lateral incisors do not have these type of solutions, neither do molars or lower incisors. Bodily movement, again, when we discuss that with braces, we know that it's more of a ratcheting type movement. With aligners, if we look here, this is a lower incisor extraction that we treated. If I want to get root parallelism, and I mentioned that we're pushing above the center of resistance, two things really, three things I think we need to consider. One, you need to have an attachment because we need those solutions to push on, as I mentioned, to get the root tip. So because for a lower incisor, for example, there is no root control attachment, I went ahead and added the vertical. I did the same thing for the cusp in this instance. Two, you want to consider over-treating the movement or adding a gable bend. In this instance, we call those gable bends virtual gable bends. So we tend to push the root into the extraction site first, then we upright the crown over the root to eventually get root parallelism. Because if I just push the crown in, I'm going to get tip of the crowns and lack of root parallelism. The third consideration is what I mentioned in the beginning, which is staging. And staging helps to give you root parallelism, meaning I can tell my technician, please open 0.4 millimeters of space, mesial and distal to the lower right, 1, lower left 3, for the duration of the space closure. So I get a full wrap of plastic around those teeth as they're moving, and that will give me better control of the root, better bodily movement. So those are really considerations. You can attachment design, gable bends or over treatment of the root tip, along with staging of movements to increase the predictability of how your roots move. So for example, this is a premolar extraction case. We see I'm staging for a full wrap of plastic. We see we have the attachments necessary for root tip. I will tell you that this is not my best design of attachments ever. And I show this as kind of, again, a learning example. If you look at the design on, let's take the cusp, for example. The canine has an oblique orientation to it, whereas the canine here has a vertical. If I was to redo this clean check, and if you look at any of my clean checks today, I rarely ever use vertical attachments anymore. Hardly ever. Why is that? Remember, all teeth in an aligner, as I mentioned, feel intrusion. So this attachment has plenty of surface area to push on to keep the tooth seated during its movement, but I still have the surfaces to push on to get root tip. A horizontal attachment has the same surfaces to push on for root tip as a vertical. I still get moments around the root apex. But what I don't have in this attachment in terms of retention, I do have here. So please always try to design your attachments at an oblique whenever possible, because you have all the push surfaces necessary for tip if you need tip, for rotation if you need rotation, but also for retention, which again is the most underlooked aspect of clear aligner therapy in my opinion. But the staging here makes this important. So this is this patient's finished result. She did have one refinement in the interim. And again, we had nice root parallelism of the premolar and the molar, which in that right side we pulled a 5, on the left side we pulled a 4.
Maz,
Yes.
we're having some audio issues. What's worked for me in the past in these situations is if you might want to try turning off other devices at home. I know with kids on Zoom and all that, it might help if you try turning other devices at home off so that the connection is better. Let's see if that helps.
Mo, are you having the same are you hearing me the same way, or is it individuals having the issues? Meaning,
No,
are you hearing my audio? Okay?
I've experienced some of it. Some people might be getting it more than others, but it does break up a little bit every now and then, and it might help if and a lot of different people are getting it. So I think you might want to try turning off other devices like your phone. If you turn off the Wi-Fi on your phone, and it seems to help. It seemed to help me in the past.
Can you forgive me one moment, and I can try something really quick to see if I can improve it? I'll have to step away for 1 minute.
Thanks. It's worth it because I think a lot of people are sending the same type of concern.
I'll be right back. Let me do that real. Thanks.
Thanks, Maz. Sorry about that.
No, don't apologize. I want to make sure that everyone's getting a positive experience from this. So what I've done, I've hardwired my computer in now, and hopefully that should give me direct connectivity, so the Wi-Fi is out of the question, and hopefully that takes care of it. But just please give me feedback, and I'll try to do whatever I can to improve it.
Thanks. Appreciate it.
Great. Okay, so just continuing on the biomechanics here and talking about torque. Torque, of course, is twist, and with fixed appliances, it can be a stubborn movement. It's important that we understand that we compensate our fixed appliances for the difficulties of torque.
Mas, just a really quick thing. Sorry, we're getting a lot of requests for you to repeat the extrusion part. I think they missed it and they couldn't hear it properly, and a lot of people are wondering if you can just kind of repeat that extrusion part again. And there are also questions about, while you're at it, questions about the pre-activation. Does that come built in, or do you have to request it? Just if you could clarify that while you're talking about the extrusion, please. Sorry.
Happy to. So let's, since I was apparently cutting out and hopefully things sound better, I'll go ahead and rephrase the extrusion part of the lecture, where essentially I was trying to explain that there's two types of extrusion you can get within an aligner that are going to affect the quality of the movement. And I think that's a word I did not use previously, but it's important to understand that you can have different qualities of movement. So for extrusion, the best quality of movement is an extrusive movement that occurs when the tooth is moving lingually. Because again, a side effect of lingual movements clinically is extrusion. You get a resultant extrusion from that. So the laterals for this patient are moving lingually for the duration of treatment for the most part, meaning that they're naturally feeling a tendency to extrude anyways. The upper left one in this instance is going labially, so it's actually feeling for intrusion, but that's the position needed to go for and lining. So that's more considered a pure or absolute type of extrusion, and generally speaking, that has a less predictable type of path. Having said that, if you have a compliant patient,
Maz, I think some people have a theory about what's going on. They're saying that every time the animation's going, the voice breaks up. So maybe if you're talking at a time when the animation is not running, that they seem to think that every time the animation's running, the voice breaks.
That's interesting. Okay. So I will, if I proceed past it, like here, we're okay?
Yes, I think
okay.
that's the observation.
Got it. Okay. So just to recap again, and I apologize, I'm not really sure what's going on. I've done many, many Zoom calls over the past couple of months, and I unfortunately haven't had that issue, but you know, Zoom can be unpredictable at times. The extrusion, again, the quality of the type of extrusion is better when you can get it to happen concomitantly during lingual movement. So if you have IPR, if you have arch development, or if you have extractions, that's going to help, I think, the quality of the movement. If you have pure extrusion and you're forced to just purely pull the tooth down, push the tooth down along the long axis, let's say that you have an edge-to-edge class 3 malocclusion with a reverse smile arc, and you wish to extrude the anterior teeth, but you can't move the teeth lingually because that'll make the class 3 worse. You know, what do you do in that instance? Still get that type of a movement, but you have to stay on the patient, meaning this is an unpredictable movement. It will happen, but you have to be 100% on board. I want you to change your aligners weekly, but do not change them until they fit, meaning that you have to really educate them on fit, because it's a less of a quality of a movement. It's going to be less predictable. So this patient was one that we opted not to do restorative on, so I was leveling gingival margins, and as you can see, there was quite a step in the incisal edges, so we went ahead and smoothed things out and finished the patient up there. With the optimized attachments, just again as a summary, it says here that these are triggered when there's greater than 0.5 millimeter of movement. So they're automatically placed by the software, and they're ranked actually fairly high in terms of, in an open bite case, these will take precedent over many other types of attachments. And we'll start talking about hierarchies a little bit later on tomorrow. But again, they generally trigger pretty readily. And with these type of attachments, what's important to realize is that when you look at the design of them, I was saying before, they're my favorite attachment because I think a lot of thought went into them, and I think they're very elegant. So looking at this, the actual attachment itself is thicker labiolingually, the attachment on the tooth, than is the well for the attachment. So when the patient goes to seat the aligner in, the aligner is pushing against that thicker attachment and forcing it into the lingual wall of the aligner. And furthermore, there's a deflection or an activation here that is further pushing that against the lingual wall of the aligner. So when we are extruding teeth with an aligner, we're not pushing down the long axis. We're pushing the tooth lingual, which, by the way, is why the quality of the movement improves when the tooth is moving lingually. So having said that, there was a question, is the pre-activation, is it requested or is it built in? You can see here, it's built in. It's automatic. It's part of Invisalign's proprietary nature. These activations are all part of the process. They're all built in to the system. You don't have to request anything. And that's why, generally speaking, again, in a compliant patient, extrusion is a very predictable movement, meaning you get it. I think the question as a profession that we always ask is it stable? And that's a different discussion, right? Will you get the movement clinically? The answer is yes, but can you keep it there is a different question. So, and we'll discuss that tomorrow. We'll discuss that. Certain types of extrusion, you may not be able to get an attachment on. So at that point, you just get creative, right? So you can bond buttons, you can do bootstraps, you can use TADs, you can pull the aligner from the tooth. I was saying before, these are challenging mechanics, so I tend to really charge a lot of money for these cases because these patients tend to be very picky, and they've usually gone to like 4 different opinions because they want Invisalign. Everyone keeps telling them they need braces. And I probably would tell them up front too, you need braces, but I can do it with Invisalign, but it's going to take longer. And as long as you're honest and you charge for it, you know, we do these things, but these are cases that have 2, 3, 4 refinements to get to where you need to be. Is it possible? Yes. Is it worth it? Probably not. But again, you have some people that are just demanding, and if they're aboard for the ride, then I'm happy to take the ride with them. Tipping, and Mo, I'm not sure if you're still there. Should I continue to just go through the lecture, you think? Was it just the extrusive portion that was negated, or can I jump back to torque? Let's see.
Sorry, I'm muted. I was on on the phone with Tiffany here. When you're, it's working. The audio is much better since you started not talking when the video is running at the same time. That made a huge difference. I'm okay. It's up to you if you want to stop and take questions, or if you want to continue and then take questions later after torque. But this audio is much better at this point.
Okay, good. If you don't mind, I'll jump back to torque then. Is that okay?
Yep, I think you're good.
Okay, excellent. Thank you. All right, so let's go back to torque here. So again, torque, let's pull this up. Sorry about that. We jumped ahead. Let me pull this up here again. So torque, as we were saying, is really twist. And for Invisalign, what they developed back in 2007, I believe it was that long ago, but they have what are called power ridges. And the power ridges can be triggered at the cervical of the crown on the labial, or at the incisal edge on the lingual. And when you see that F2, which is the lingual power ridge, that's triggered when the software detects that there is no lingual centric contact. So for example, in a class 2 div 1, if there's excessive overjet, you will get that F2 power ridge triggered, so you can get an semblance of torque during the correction of the malocclusion. With torque in and of itself, again, it's a complicated movement. I want to just talk about some considerations. So this young man came in and he was interested in Invisalign, and you can see his chief complaint here was really the high cuspid. He did not like that. So we went ahead and put him into Invisalign, and we comprehensively treated the case. And he came back after his first set of aligners looking like this. So that clearly is not what we intended. And what happened here? And I think it's always important to ask that. Did I blame the appliance? Probably at that time a little bit, because I was just starting out. But really, I've learned to blame myself more than anyone else, and I made some mistakes here. So first things first, you can see that this patient's curve of Spee deepened anteriorly, and that the incisors basically lost torque during treatment. And why did that happen? Well, if you go back and look at the case initially, there was some level, even though we did have some crowding around the canine area, there was some level of space closure occurring in this case at the diastema. Furthermore, I probably should have, in hindsight, built up the laterals on this case, because you can see there's a Bolton discrepancy here, as well as propping the bite open. So we lost torque because of space closure. So whenever you close space, you need to add torque. That's one thing. 2, there's a Bolton issue here. 3, he's a teenage boy. So what do teenage boys do? They grow. And I did not have class 3 elastics built into this case. So we put this case into refinement. We intrude and add torque to the upper 2 to 2. We start running some class 3 elastics, and we will look at how the outcome turns out here in a moment. But the case is here in the point is that when you lose torque, and this is from Andrew's 6 keys of occlusion, it distalizes the mandible and props the bite open. So when you can correct the inclinations, everything will seat again normally. And that's very important to finishing. So you have some patients, for example, that may have really thick lingual marginal ridges, and it affects your ability to seat the occlusion. So all these things, again, in terms of looking at your centric contacts, play a role. So that could be the Bolton, That could be the marginal ridges. That could be torque, for example, again. So you want to really think about torque and over-treating it just like you do in fixed unintentionally. Again, all of our fixed appliances are over-treated for torque. You don't always finish in a full-size wire. It's there for you if you need it. So we want to over-treat the torque as much as we can. So looking at this, let's talk about that. Your pre-adjusted appliance, your straight wire appliance, has tip, torques, and in and outs. But one of the reasons that we may forget about that tip is built into, especially the upper brackets, is to compensate for torque. So what does that mean? Again, Andrew's 6 keys of occlusion. For every 4 degrees of lingual root torque that you get, there is 1 degree of mesial root tip of the crown within the alveolus. That phenomenon is called the wagon wheel effect. And our straight wire appliances, our pre-adjusted appliances, add in distal root tip to offset the mesial convergence that happens during torque expression. So if that's the case, and we have a rectangular NiTi going in the patient's mouth, because that's the analogy I draw with Invisalign, in the patient's mouth day 1, so we get that phenomenon of the wagon wheel effect. When you have power ridges, and they often don't seat like this, is that because of the power ridges themselves squeezing the tooth and it's falling off? Is it because you can't have an attachment on the teeth when you have a power ridge? Or is it because the roots are converging and you're not having an attachment on there to offset that side effect? I'm asking you these things, hypothetically. I don't know the answer 100%. These are conjecture, but I often have this issue with power ridges when I don't have attachments on adjacent teeth or on the teeth that are moving, which again, you cannot have at the same time. So let's look at something here. Recently, and by recently, I'd say it was probably about 2 years ago. I'm going to pull up a ClinCheck here, so hopefully you'll be able to see this in a moment. Give me 1 second to pull it up. And this is still pulling up on my end, so I'll let you know when it's on the screen here so you can see it. Okay. So here we have a ClinCheck, and I'm going to go ahead and on this ClinCheck pull up the 3D controls. Historically, when we had ClinChecks and torque was being added, you would simply see the torque expressing, but you did not see any type of ancillary movement occurring. You didn't see anything additionally occurring. So let's say we have this ClinCheck here, and we were going to take the upper incisors, which have power ridges on them. But for the discussion, we're going to grab these 4 incisors, and I'm going to add more torque. If you look at the crowns and the roots, you can see, I'm exaggerating, that the crowns go like this. They start to splay, and the roots start to converge. So how do you offset that side effect? Well, you would need to go ahead and grab the teeth here and add in your artistic bends or your distal root tip to offset the side effect of what happens when you add torque. Well, if I'm adding in distal root tip though, what do I need? I need an attachment. So doesn't that conflict what's trying to happen here? And the answer is that yes, it does. And you have to, again, take considerations as to what's happening overall. So let's go back to the presentation here and we can kind of talk through that. So first off, when I'm asking for torque, I always look at my Ceph, and let's say based on my Ceph measurements, upper 1 to SN is at 95, and I want upper 1 to SN to be at 105. So I ask my technician, given that there's 10 degrees of torque needed, I say, please give me 20 degrees of lingual root torque. What I just do, I just double the torque. So generally speaking, I try to double the torque, especially in adult patients, when that's an important outcome that I'm looking for, because torque lags in the aligner. It definitely is a low and slow movement, and it requires overtreatment. Furthermore, when you look at torque as a movement in your treatment planning case, you have your step to consider what you said, but you also have how the occlusal plane is set to consider. When we're virtually treatment planning, the occlusal plane is set parallel to the floor, but that's not how human beings walk around. According to Downs, the average occlusal plane is at 9. So you can see here that we actually lose information on perceived torque when you have an accurate occlusal plane put in the software versus a standard one that is done virtually by the technician. So for example, in A at top, these are differences in projections here. This is a flat occlusal plane, which is what Invisalign gives you. You can see that here, the contour or the convexity of the labial surface of the crown pretty much hits what we would want in terms of where the light hits the tooth or what we would want aesthetically. And we may not want to change the torque in that situation because we would think it's adequate. But as the occlusal plane steepens here, we can see we actually lose torque. And so you may want to add more, again, based on what your goals are for the patient. There is an ability within the software to change the occlusal plane angle. So if you go to Tools and Set Occlusal Plane, you can change the roll, the pitch, and the occlusal plane based on what your goals are again, but that's something that you need to set on your own. Your technician is not going to do that for you. So again, this is just showing a ClinCheck standard at the average occlusal plane according to Downs, and one that's more steep, how much more torque you would need in certain situations. But this is the same malocclusion, just set at different occlusal plane inclinations. So with regards to, again, power ridges and torque and just the movement overall, I do often remove power ridges due to staging conflicts if the power ridges are on all 4 teeth. If I have a situation where power ridges are on the upper 2 to 2, that makes me nervous, honestly, and I tend to at least remove the ones on the laterals and add retentive attachments. The other thing I ask for, generally speaking, is to, of course, double the torque that's shown, especially in adults. Again, you need to overtreat it. And to control the root, what I would recommend is to ask your technician to please give me 0.2 to 0.3 millimeters of space during the torque correction, so you can have the surfaces available to build in your artistic bends and take into account the wagon wheel effect to have your tip built into your pre-adjusted appliance so that you have root parallelism at the end of treatment. Because otherwise you may find yourself with an ill-fitting aligner or convergence of your roots during treatment, which we of course want to try to aim for root parallelism when we're done. The other thing is that, as I mentioned, this is a low and slow movement, meaning it needs time to express. So please make sure that you are not expressing more than 1 degree of torque per aligner. And the other thing that will help you, in my opinion, is to try to build in some intrusion, if you can, of the aligner during the torque expression. Automatically, whenever I say that, I always get the question, well, what if you don't need intrusion? Remember that intrusion, generally speaking, is another movement that really doesn't express very well. So that intrusion you're building in is simply to help seat the aligner to get the torque expression. It's not going to flatten your smile arc, or it's not going to open your bite up. It's pretty much not going to happen. If it does, you can relapse things back together at the end of treatment. It's more important to get the torque to express. Because if you didn't get that to express in the first set of aligners, well, now you're trying to get it to express in your refinement, and your second refinement, and your third refinement. So you really want to go for it in the first set and then detail in the second set. So I've found that cases where I build in some intrusion, it really helps to have the torque to express properly. So let's take a look at just a case that was treated out here, and I want you to see how the teeth are moving. That generally speaking, as teeth tend to express their torque and they're moving labially, there's some level of intrusion that's occurring, and then we will go ahead and overtreat the intrusion at the end of the case and finish the case with exaggerations, and not only the torque, but also the bite opening. And notice where the case actually finishes. We really fall somewhere in the middle of all of that. So if I did not overtreat the torque in this case, if I did not wrap the teeth in plastic during the torque expression, if we then have attachments to the adjacent teeth, we would generally fall short again of the overall movements. I do perform at times, I see sagging of the aligner, which you see here, micro-osteoperforations to try to increase the rate of bone turnover there. I do not do this to speed up movement. I don't do this in the interest of speed. I do this in the interest of creating inflammation, to try to get better turnover of bone, to help unlock movements if they're being stubborn. So we do use that as an adjunct to treatment when we need it. On the topic of torque, what about buccal root torque? Unfortunately, at the moment, there does not exist attachments for buccal root torque in the posterior. The only instance of where these exist are for Invisalign First. So Invisalign First, where there's a lot of arch development, they will give you retentive attachments to help build in some.
Hey, Dr.
Yes.
Dr. Mashiri, sorry, it's Tiffany. Excuse me for just 1 second. It's just going a little bit fuzzy. I wonder if it's because the animation. Yes.
Yep, so let me jump past it.
Wonderful. Sorry. Yeah, that's great.
Good. So as you notice on buccal root torque, oh, Tiffany, can I ask you a question real quick?
Yes, of course.
When I had the ClinCheck up, when I was actually moving the teeth on the ClinCheck, were you having the same problem of fuzziness? Did anyone...
The same sort of fuzziness, but you were speaking sort of around it. But yes, was it a different type of slide? Is that right?
Got it. Thank you. So if you notice from that slide, in the interest of hopefully keeping the audio clear, I'm going to get off the animation. When you are expressing buccal root torque and you have a molar, and let's say that this is the palatal cusp, so it's lifted up, and you want to, excuse me, opposite. We want to create buccal root torque. We want to lift that palatal cusp up. You need to have an attachment to push down on the buccal. And again, you don't get that automatically in the software. So if you have buccal root torque, or if you're doing a lot of arch development and you're concerned that the buccal cusp may intrude and the palatal cusp may extrude, you need to add an attachment to the buccal to help you push down on, to help seat the tooth within the aligner to prevent that from happening. With that being said, at the moment, Mo, I think this is a good time to take questions. And then I have a slight more on biomechanics, not much, and then we'll kind of get into some of the other considerations for class 2 and class 3.
To be honest, the majority of the questions were related to audio. There was a question about molar intrusion and how you achieve molar intrusion. But otherwise, and then there was that question about the regarding the activation. My understanding is that if you get a horizontal bevel detachment that's optimized for extrusion, then you get the pre-activation. But if you select a horizontal bevel detachment from the attachment interface, my understanding is that those do not have the pre-activation. Is that correct? I can't hear you. You're muted.
Can you hear me?
Yeah, I can hear you now.
What you said is exactly correct.
And there was one question about that pre-activation. They wanted the details. And then there was a question about molar intrusion. How do you achieve it? And I think the rest of the comments were all audio related.
Okay, thank you. So
there's also one that just popped up here. What type of material do you use for the attachments, especially the optimized attachments?
So, Mo, first of all, can you hear me okay? Because I have a ClinCheck up. I want to make sure that during the ClinChecks, it's not too much audio distraction.
I can hear you really well right now.
Okay, good. So yeah, I'm going to share this ClinCheck. I just want to make sure that wasn't causing too much distraction there. So with regards to attachment material, I don't necessarily differentiate between optimized and conventional. For all my patients, I use a heavily filled restorative composite, which is 3M Filtek, Filtek Supreme Ultra. And I found that we just carry one shade. It's shade A2, which tends to blend in with the teeth very nicely. And Invisalign only recommends really heavily filled composites because I think they hold up to treatment, meaning that as the patient takes their trays in and out of their mouth constantly, it tends to rub the composite down. So you want to make sure that the integrity of that attachment shape holds up. So a restorative grade composite not only is generally heavily filled, but which means it'll hold up, but also it's more stain resistant. Now you do have exceptions, people that have high diets in curry, turmeric, drink a lot of wine, mustard, some staining in some instances can be unavoidable, but they tend to stain much less. So that's why I use those composites specifically. So Mo, anything else before I go on?
I think you're all set.
Excellent, thank you. So one thing I wanted to show you here, remember when I was talking about optimized attachments, is that when you're designing your attachments and you decide that you need a conventional attachment is given, or you use it because either conditions and thresholds are not met, so you need to design your own attachment, or it just doesn't exist for that movement you're looking for. So for example, I've said it before, like a lower incisor that needs root tip. So let's look at this lateral though, because laterals tend to be very pesky and stubborn at times. So this lateral incisor does happen to have an attachment on it. And if we look at this attachment, it's for a distal in rotation. Well, when I look here, is this attachment that's going to work for this patient? The answer is probably yes. It's not a very significant rotation. And given I think what I'm seeing, I'd probably end up leaving it. But let's say that this rotation was more substantial, or let's say that you didn't even get that attachment, because that happens. Where you see a lateral rotating, or you see a tooth rotating, you know what, I just don't feel comfortable here. I need to make sure that I have an attachment on this tooth. How do we design it? How do we design our attachments for predictable tooth movement? Well, let's go ahead and add an attachment to this tooth. And let's just make this a 4 millimeter. That tends to be my average size of attachment that I add. And let's say for demonstration purposes that this tooth is going to be rotating distal in. And I'm going to exaggerate the movement. Okay? So we're rotating this tooth distal in with treatment. So as I've mentioned before, it may be intuitive for us to say, oh, this tooth is rotating distal in. So I'm going to go ahead, give this attachment as much surface area pointing in the opposite direction. So the aligner, as it pushes here, can push against this large surface area to rotate that tooth distal in. And that seems fairly intuitive. But remember, we're not taking into account what the tooth is feeling. And the tooth in the aligner is feeling intrusion because it's getting squeezed. So to negate that feeling, we have to give that attachment and the aligner a surface to push on here to keep the tooth seated in the aligner during the rotational correction. So if you recall what I was saying, how do I orient the push surface? I orient the push surface so it is perpendicular to the sum of the net forces acting on the tooth. So the sum of the net forces here are for distal in and for retention. So the sum of those two vectors is here. So now we are perpendicular to the sum of those two vectors. So that's how you need to design your attachments whenever you make conventional ones. Let's say now that this tooth though, and before I move on, notice again, if we just for reference, look at the optimized. This is a mesial in rotation on a canine, you see? And pretty much we have the same angle with which to push on. So the same considerations are given to conventional attachments as well, where you have to do them. Well, let's say now that this tooth has root movement. So the root needs to move, and there's a lot of tip here. So we're going to grab this tooth, and again, for demonstration purposes, we're going to say that this tooth has a lot of root tip. We're going to give this a lot of mesial root tip for demonstration. So how is the aligner going to do that? Well, what I immediately think about is, do I have the push surfaces necessary to get that root to tip mesially? And so we could say, well, to tip it mesially, the aligner could push up here maybe, but where is it going to push down on to get that counter moment around the root apex? Because ideally, you want those surfaces to be contrasting. You don't want them to be at any type of deflection or angle from each other. So really, that doesn't exist here. If I took this attachment, let's say, and maybe I removed the bevel from it, you know, now I have two flat surfaces to push on here and here to get that moment around the root apex. But that, in my opinion, diminishes the efficacy of the attachment, because this attachment, now that we have a 90-degree angle on it, makes it so it doesn't track as well. There's more chance for that aligner not seating and snapping over that 90-degree angle than there is of it actually seating and properly engaging this tooth when the attachment's beveled. A beveled attachment has much more forgiveness and much better tracking than generally does one that has a 90-degree angle to it. So what do I do? What do I do here? Because if I like that attachment because it's helping with the rotation, but I have root tip, what do? Well, you can open space. So I'll tell my technician in an instance like that, if there's a lot of root tip, please do not start to move the root until I have 4/10 of space, 4/10 of a millimeter of space, mesial and distal to this tooth. And what that allows for me to have now is surface area interproximally, because now I have two contrasting surfaces to push on to grab that root to get the root tip. So this illustration of what I'm demonstrating here applies to every single tooth in the mouth. When you have a situation where conditions and thresholds aren't met, where you don't have the design to get predictable tooth movement for what you want, or if a solution just simply doesn't exist. So again, that's kind of hopefully summarizing some considerations here for how we're going to design attachments and ClinChecks to get more predictable movement. I'm going to share my presentation again here. Yes.
Before you kind of move on to the next point, there was a question about, you were mentioning something about controlling torque on the molars, and then you said something about Invisalign first, and I think you were breaking up at that moment and they didn't quite get what you were saying about Invisalign first when you were talking about the buccal and lingual attachments for buccal root torque on the molars.
Thank you. So Invisalign First is the only appliance in Invisalign's repertoire, if you would, that actually takes into consideration adding an attachment for buccal root torque. So Invisalign First, with that appliance, you do get an attachment to prevent, during arch development, to prevent that buccal cusp from intruding and from the palatal cusp from extruding. If you don't have Invisalign First and you're using just a comprehensive Invisalign product and you're doing a lot of arch development, or if you need to have buccal root torque added, you need to add your own attachments. At minimum, you need an attachment on the buccal because you have to push down on that buccal cusp to help level the curve of Wilson. You technically have the palatal cusp to push up on to get the counter moment, but if you add an attachment on the lingual, that gives you more twist. But sometimes that's kind of challenging because based on how much torque you need, the patient could be occluding on the lingual attachment. So it just depends. If you can sneak it on there, if you have enough real estate to put it on there, great. But at minimum, again, you need the attachment on the buccal. And again, as a consideration, you don't get that through the optimized attachment selections. You have to add that yourself when you have a lot of arch development. And we're going to talk about that. I'll expand on that a little bit later today as well. So this is what I was talking about too with regards to optimized attachment size. If you notice the size of this optimized attachment, it's at an oblique. It's a nice size attachment, but this is not the default, meaning that you have to go into your doctor preferences and select that you want the largest optimized attachments for the front, anterior, and the posterior if you wish to get larger optimized attachments of that size. Let's look at another example here. This is a gentleman that came in that his chief concern was his lower anterior crowding. We have a situation here where we have a canine, however, that has a lot of distal root tip that we need to correct, but it also has a mesial in rotation that's needed. So what's going to happen here in the software is that the software needs to make a choice. Is the root tip more important, or is the rotation more important? And again, the software here had to make a decision, so it chose rotation, but that attachment does not have the surfaces to push on to get the root tip correction. You can imagine where the root is going here, right? So clinically, we have a failure of the movement. And again, the software had to make its decision. It chose a rotational attachment. Tooth stops tracking. I put a bootstrap on it. I tried to capture it. That was a mistake. You can't do that, okay? You can put a bootstrap on an extrusive failure. You can maybe put a bootstrap on a rotational failure if you can apply a moment with your bootstrap, but you cannot bootstrap a root tip failure. So this truly needs a refinement and a redesign. What would be the redesign? Either getting a G4 attachment on there, assuming the rotation was corrected, or probably keeping the same type of attachment, but opening space around the tooth mesiodistally, so I have a full wrap of plastic. So again, certain considerations for what need to happen. So we had to do a refinement on this gentleman and recapture the case. So again, with canines, the considerations for predictability are, is there an attachment? Probably, but is it correct? You have to look at the sum of the parts. Is there root movement involved? How do you know? Sometimes you can't tell. Look at your tooth movement table. The tooth movement table is a feature of Invisalign software that shows you individually to what degree the movements are happening. Is there extrusion involved too? You got to look at all those variables. Solutions, if it's rotation only or rotation with extrusion, consider the sash type attachment, which is that oblique attachment I was talking about. If there's root movement, either add a long vertical attachment that you can kind of rotate at an oblique orientation, or again, I think what's better, as I mentioned, is to create plastic wrap, because that attachment, if you make it a long oblique and don't bevel it, it has more of a chance to not track in my experience. So I think wrapping it in plastic, but keeping an oblique attachment on there that is beveled to the gingival is the best solution overall if you do not get a better solution from Invisalign. One question you could ask is, well, could I keep the optimized attachment for rotation and open space mesiodistally? Yes. The optimized attachment for rotation has the surfaces you need. That is basically, it's a beveled oblique attachment is what that is for rotation correction and for retention, assuming you don't have a lot of other movements adjacent that are happening. So if I have and I'll show you in deep bite section, if I have a lot of anterior intrusion occurring, right? A lot of anterior intrusion, and my canines rotating, is an optimized rotation attachment strong enough to support for anchorage all the anterior intrusion that's occurring? Maybe not. So then you have to put that oblique attachment because it's more surface area for retention. So again, it all becomes just taking a global view of the sum of the parts. I'm going to pull up another clin check here for you. So bear with me as I pull that up for you here in a moment. One mental exercise that I think is good to do, that I did a lot in terms of my learning experience, was when I was beginning to look at fin checks, I would actually turn the attachments off, because sometimes it's hard to see past the attachments that Invisalign gives you.
Hi, Dr. Moshieri. It's Tiffany again.
Hi.
I'm so sorry to interrupt. It's just getting a little bit fuzzy once again.
Would it be worth it for me to log on and log off and log on again, do you think? Because I've never had this issue before on a Zoom call. So I'm thinking it may just be a bad connection. Is that
Absolutely. We can certainly wait. Absolutely.
Great. So let me log off and try to log back on and see if that helps.
Great idea. Great idea.
I'm going to stop sharing. I'll be right back.
Super.
Thank you.
Thank you for your patience, everybody.
I'm sorry that's happening. Okay,
That's great, Dr. Mashiri. Welcome back.
thank you. So
It's a
hopefully,
nice,
I'm not sure if that makes a difference or not, but the only thing we can do is try.
excellent.
Let's see here. All right, so let me go through this if you would. Now I'll try to pull out that ClinCheck again and see if that works. Okay, sorry, this ClinCheck's pulling up. All right, so what we were saying before, and hopefully, I'm hoping praying the audio is better here. It's a good mental exercise to visualize your ClinChecks without attachments on, especially when you're just really starting to treatment plan with aligners and getting used to the nuances of things. So if we look at this case and I start to play through the movements anteriorly, what you're going to notice is that we get some arch development first, and then look at the incisors. So if you ask yourself here, what attachments do I need to make these movements predictable? You can see the laterals have rotation and extrusion. You can see the centrals have rotation and extrusion. So in my opinion, the movements that fail the most, if not accounted for, would tend to be extrusion because the tooth does not have a natural undercut. So if we look at the attachments that were placed on this ClinCheck, we can see that I added sash attachments to the laterals, but the centrals had G4 placed in the software. So where is the push surface on this attachment for extrusion? Well, it really doesn't exist, right? So as we go through here, I'm going to jump back to my presentation here.
The sound is great, just so you know.
Awesome. Good. That's good news.
Yeah, the sound is better, but for some reason they have you labeled as me, but I don't care as long as it sounds good. Let's keep going. Underneath your name, underneath your picture, it has my name, but I don't know how that happened, but let's just roll with it because you sound really good now.
I'm honored, and if that's what it takes, we have the same initials, so I think it works out okay.
Yeah, it does.
So if we look here, you can see that this patient then now has a clinical failure. The laterals are tracking just fine because we designed the attachments properly, but I missed the fact that the centrals did not have an extrusive push surface to stay seated within the aligner. So again, biomechanically, I'm just trying to show that it's not only the quality movement, but the attachment design and all these considerations have an additive effect. This is the last example of individual tooth movements that we're going to discuss, and then we're going to start kind of getting into comprehensive cases here. But this is a young lady that came in who was primarily concerned about her right cuspid, which you can see has rotated, and she had previous forebone extraction. I was, of course, going to address her chief complaint, but I was also concerned about the lower left second molar being mesially inclined and dumped in. So we went ahead and had her wisdom teeth extracted and designed a force system to try to get that tooth to upright. And remember, there does not exist a root control attachment for molars. So when you look at root control for premolars and molars in terms of just kind of grouping posterior teeth together, are there optimized attachments for premolars? The answer is yes. Are there optimized attachments for molars for root tip? The answer is no. So what are your considerations and solutions? You can either add, a long vertical attachment, which again, I mentioned, I tend not to use anymore, but for whatever reason, I think conceptually, I always thought, well, if I had a long vertical on there, it's in the same line as the vertical axis of the root, so that must be the best attachment. And again, I just want to emphasize that that really is not the case. If you think about it, all you're looking for is surfaces to push on to get tip. Well, if it's horizontal, you have surfaces to push on to get tip, but you have retention. So for root tip, whenever you can, my recommendation is to get a horizontal attachment on there overall. So in this instance, what I did for this patient, I gave him an attachment to push on, not only to upright the tooth distally, as you can see, but the attachment on the distals to push down on as well. So we need that moment needed to help upright the crown and kick the root medially as well. So you cannot add on your own 2 attachments to one surface within the software. So you can add one and request another, and the technician will give that to you. One of my counterparts and colleagues, Jonathan Kazistis, he calls this a twin.
Hi, Dr. Moshieri. It's Tiffany again. I'm so sorry. Just when it's moving, it's happening again. It's just a little bit.
Okay, so I'll pass this up, but just again for clarification. Sorry.
No, that's terrific. Thank you.
So for clarification, you cannot add 2 attachments on your own. You need to ask your technician to help you with that. And if you request a twin attachment on a molar, the technician generally knows what that means. So if you say, I want a twin attachment for root movement, they'll give you 2, go and orient them how you want to get the movements you desire, and then you can get more predictable root movement and uprighting of your molars. So this is showing this patient after the first set of aligners, showing the molar fully uprighted, again, and for reference from pre and post to where the tooth movement went. So given all these considerations that we've discussed biomechanically speaking, it's not meant to overwhelm, it's just meant to say again that there's a lot that we need to think through. And the beauty of it is, it's like anything else you do in orthodontics. You do it over and over and over and over again, and eventually you don't have to think about it. But in the beginning, you certainly do. And, you want to wrap your head around it so that it becomes a habit for you. It's like anything else we do in life, the more you practice, the easier it becomes. But there's definitely nuances involved with this. So how do we communicate some of these things to our technician? Because it's important, because again, what we get back from Invisalign is a really good first guess. But we need to then customize and bend that plastic to get more predictable treatment for our patients. And the goal of doing this, of course, is to decrease time communicating with the technician. Because yes, do I need to talk to them here and there? To an extent, but I'd rather really use the 3D controls as much as I can to basically design things as well. You want to improve predictability of movements, and you also want to decrease treatment efficiency by having a more predictable overall plan. So again, when you look at your technician, I have the fortune of having my own technician that I've had for years. Her name is Susie, and I've met her in person. I've communicated with her, in person in Costa Rica, but I still go through and I have like probably 2, 3, 4 iterations of every ClinCheck to get it right, even though I've been using her it's been 10 years now. So, we're both human beings, and we both are trying to speak the same language and share the same brain, but it's not going to happen. So at the end of the day, again, I think the doctor needs to take really control, and knowing again, when is it appropriate to use the optimized attachment given to you? When is it appropriate to change it? When is it appropriate to add another attachment? When is it appropriate to overtreat certain movements? We have to customize all of this on our end. So I think it's important to have systems. And when you look at your ClinCheck, it's important, I think, to have a routine of how you dissect the ClinCheck. And first things first, you got to check the bite. Now that seems kind of silly if you're scanning, because you'd figure you have it right all the time, but that's not always 100% correct. And if the patient has a CRCO slide or shift, if your assistant's scanning the patient, they're not biting correctly, you can have a problem there, a big one, because you're treating to the wrong bite. And that's going to create problems, especially if you don't bother to check the bite against your photos you took and so on and so forth. So once you confirm the bite, it's important to look at the two-size discrepancy. Why is that such a big deal? Because with braces, we can compensate two-size discrepancies much more readily. With braces, I react at every appointment, meaning I do things at one appointment. I say, see the patient back in 2 months. Patient comes back. I look, I react. I say, occlusion's tight, buccal occlusion still class 2. I have to have overjet to coordinate the arches, and there's a two-size discrepancy. But the patient doesn't want buildups, let's say, or I don't want to do IPR. So I'm going to step up the upper anterior, or I'm going to step down the lower anterior, or I'm going to add lingual root torque. I'm going to do things on the fly to make adjustments to address that Bolton discrepancy. But I'm leveraging the strength of the straight wire appliance. I'm leveraging the strength of braces. Because braces, in the finishing stages, you have stiff materials in your hand. And if I need to compensate a Bolton with intrusion of the upper or intrusion of the lower, I can easily do it with braces. That's not easy to do with Invisalign because, again, we're making these adjustments with a nine-tie wire. So addressing the Bolton and understanding that for your patient becomes very important and can lead to a lot of finishing issues. Once you know your Bolton and how you want to tackle it, you got to figure out, am I going to address it with IPR or am I going to address it with opening space? And most of your Boltons are probably mandibular excess from small upper laterals. So that really becomes the decision then, am I doing anterior restorative for aesthetics, for ease of really treating the case? And what do I mean by that? If I have a deep bite, do I want to do a lot of IPR on a deep bite? Probably not. If the case is an open bite, do I want to do IPR in that and maybe camouflage the case a little bit and compensate? Probably yes. That's going to help close the bite down. So those become considerations in your mechanics. Of course, assessing predictability of movements. Remember I said quality of movements, that extrusion is probably more effective during retraction of teeth. So if my technician shows all the extrusion occurring during proclination, but then shows the incisors coming back at some point during treatment, I'm going to say, hey, please show the extrusion during retraction, not during proclination. So looking at those type of nuances, adding, changing attachments, prioritizing anchorage in terms of how you design your attachments. And then lastly, looking at the interincisal angle because it almost always needs to be overtreated. Majority of the cases that you get are deep bite cases, majority of the time, I would say, in terms of what comes into the practice. So I always finish patients that present with a deep bite malocclusion with zero central context anteriorly. You have to overtreat that. So going in and dialing in your overtreatments as the last phase becomes important. Regarding attachment design, and when we look at attachments, again, we know that Invisalign has priorities for how attachments are selected for certain teeth. And for premolars, for example, number 1 is attachments for premolar extraction space closure. 2 is root control, 3 is rotation, 4 is extrusion, 5 is deep bites. That, in my opinion, should honestly be number 1. Number 1 should be deep bites for anchorage, because when you have a patient that presents to you with a deep bite, if you do not level the curve of SPE effectively in that first clin check, you cannot address the anterior posterior movements at the same time as well. So let's say, for example, in the United States, a lot of malocclusions that come into our offices are class 2s. But you have a class 2 malocclusion that is a deep bite. If you don't level the curve of SPE, you will not have enough anterior clearance to coordinate your arches. So if you don't address your vertical, you can't address your AP. And now you're stuck. And you're probably going to have a posterior open bite because you're too tight in the front. And now you have a refinement. And because you didn't eliminate that major movement in the first set of aligners, you may not even achieve it at the refinement. So now you have a second refinement. So the whole goal is here to be efficient, not burn the patient out, have good outcomes. Well, if we're treating with a nine-tie wire and that compensation is needed, you have to really exaggerate and go after the vertical day 1, because you're not going to be able to step into a heavier wire. You have to take that into account day 1. So as we go through here, and again, the teeth have different attachment designs, but we need to understand what is best for them. The generalized hierarchy for a line, this is not a tooth by tooth, this is the all-encompassing hierarchy in general, is multi-tooth movement, which is extractions or open bite closure, root movement, single tooth vertical and rotational movements, and P4, again, anchored for intrusion. I implore you that, in my opinion, P4 should be P1, meaning it should be at the top. Optimize Smart Force default placement hierarchy. The software for Invisalign does not value anchorage. It's the orthodontist's responsibility to decide the hierarchy that best fits their patient's needs. The ClinCheck is a representation of a force system, not of a result. What force system does your patient need? Only you really know. So pearl number 1 here with regards to this concept, if you do not address the vertical, you cannot address the AP, as a steep curve of speed will limit your effective overjet, as I mentioned. This is affected by your attachment choices for anchorage and the amount of overtreatment that you build into your treatment plan. This is what we're trying to avoid. In my estimate, I'd say 75% of my open bites that I would get clinically are from anterior interferences. From what, again, as I mentioned, from lack of leveling of the curve of speed, from lack of attachment design, undiagnosed Bolton, not enough torque prescribed, et cetera, et cetera. There's various reasons for that happening. So again, why do they occur? As I mentioned here, one thing that I think another thing to consider, honestly, let's go back, is also as a side effect of movement. I see this sneak up on a lot of doctors, is that when they add IPR to a case, so let's say that there's a Bolton, they add IPR to a case to address it. IPR deepens the bite. The ClinCheck doesn't show you that. So if you do not overtreat the ClinCheck to take into account the side effect of adding IPR, you will finish too tight anteriorly. So that's one that's overlooked quite a bit. So for example, a young man presents to the practice and seemingly not a challenging malocclusion, right? We have generalized spacing on the upper, some crowding on the lower, a good overbite, and he's class 3 tendency on the left. So we're gonna, treat this, if this was in braces, you put braces on and you would essentially run elastics. If there is any type of a Bolton discrepancy, consider maybe some lower IPR if you're too tight anteriorly. And so the same considerations exist with aligners, where we are retracting the upper space. I'm trying to retract the cuspid first to set up my anchorage and then intrude the 2 to 2. On the lower arch, we have IPR to address the Bolton. And at the end, you're going to see a bite jump, which is representing rubber band wear and arch coordination. So the arches coordinate. I've over retreated. As you can see, I have a little bit of bite opening in the front, but I didn't overtreat this case enough because there is a lot of space closure here. There's a lot of space closure distal to the cuspids. There's a lot of IPR I added on the lower. So this patient comes in and you can see he's coordinating on the left side. He's no longer class 3, still slightly line discrepancy, but he actually got deeper than when he started. And this is the second time I've shown you that this space closure led to bite deepening of the case overall. And for even an experienced orthodontist, that can be surprising because that rarely happens to you in braces. So please be aware that that is something that can happen in these type of cases where there's space closure occurring either from pre-existing space, like on the maxillary arch, or IPR that you added. You need to compensate the case and overtreat and bend your plastic even more than what you would think to take that into account. And what's the worst thing that can happen if you overtreat it? Because I think sometimes we get nervous. We have these ClinChecks that have open bites at the end of them. The worst thing that happens is you get to a liner 30 of 40 and you see that your ClinCheck looks good, right? That the vertical looks good, I should say, clinically. Well, you go to refinement early then. Your priority is the vertical. So once you're out of the vertical mess, go to refinement and start to detail. Because if you start to deliver more aligners and your vertical is good, you will develop an open bite. I've had it happen to a couple patients at St. Louis University during this COVID pandemic, where they had to stay in one aligner for 2 months. Well, the lag caught up. The reason why you overtreat is because of lag. The reason why you overtreat is because of the side effects of tooth movement. But if you keep the patient in the aligner for 2 months, and if you were to change your aligners every 2 months, you probably wouldn't have to do all this. but because we change them weekly, we do. So that is a consideration to have. So again, do you want your patient's mouth to look like this? The answer is certainly not, but we do this with a specific intention because we understand, given the circumstances, either there's a material property and lag issue, or it's a challenging malocclusion because of musculature. So what considerations do you take in terms of how much you overtreat? Because I get that question asked a lot. Well, Dr. Mashiri, how much should I overtreat? And my answer is, I don't know. It depends on your patient, right? Because there's many variables to be involved. One, is there growth remaining? If the condyle is growing, the occlusion is separating. So there's compensatory eruption. So it's easier to open the vertical, so you may need less overcorrection. Is there crowding versus space closure IPR need? Remember, if there's crowding and I'm proclining teeth, the teeth want to intrude naturally. So I'm going to overtreat less. But if I'm closing space during treatment, I have to overtreat much more. Have premolars been previously extracted? This is a mistake I've made time and time again because I'm stubborn and I don't learn my lessons sometime, I guess. But patients that are adults that present to your practice that had previous premolar extraction, that are deep bites, that may have had even, let's say, some relapse of the premolar extraction site, those are very tough cases to open with aligners. Because first of all, you're missing an anchorage unit. And two, if the space opened and you're closing that space, that has a bite deepening tendency. Those are gonna be very tough cases to treat, so just be careful of those type of cases. Is the patient brachycephalic? If the muscles are fighting you and you're trying to treat them with a NiTi wire the whole time, where do you think the case is gonna go? So again, we have to take the sum of the parts and understand that we're doing orthodontics with Invisalign, not just Invisalign. So there's many considerations here in terms of what we need to do. So how do we bend our plastic? Well, you want to make sure that you have some posterior extrusion built in, some anterior intrusion built in, so we're bending over the speed. That means heavy posterior contacts. When you look at the anterior here, we have attachments on 3s and 2s, as I mentioned, because we're intruding the two past the level of the cuspids. You have 0 centric contacts anteriorly. I want to see 0 contacts here overall, because again, we know the intrusion is going to fall short. We have bite turbos on the lingual of the upper 2 to 2 to help remove any unwanted posterior bite forces as well. Notice that all these dots here, that's a representation of the tooth movement assessment tool from Invisalign. If they're all black, that's telling you that they're challenging movements. Of course they're going to be black because I've overtreated them. So I don't really look at that per se, but don't let that throw you when you overtreat. All the movements are going to be perceived as being difficult because you're going to extremes there, but you have to do that to get the movements we want clinically. So considering, again, anchorage, because we were talking about it for device, we talked about that for adjacent teeth. And I'm going to try something here real quick. Excuse me one moment. With regarding the audio, I hope things are coming in okay, but I want to try something else here. So give me 1 second here. Okay, I'm back here. So, looking at just another example here of the curve of speed leveling, one consideration I want to give you, and I'm sorry here, give me 1 second. That was the wrong presentation. There we go. What we have not talked about, I mean, we hinted at it earlier, but we haven't talked about expansion. And it's interesting to look back and really sneak up on you because we talk about posterior as well. And again, mainly that can occur from anterior interferences, but the second most common reason in my experience is overexpansion. So this lady comes in and she's pointing to her jaw joints. We treat a lot of TM joint patients in our practice, and we always treat them with a splint first. I never jump in on joint patients to right into Invisalign. I want to diagnose them. And the splint we use is what's called a pivot splint. And these are used specifically in patients that have internal joint derangement. So when a patient has clicking and popping with pain or locking, this is the type of splint we give them. We're trying to increase the joint space. We have them wear this 24/7, including eating. We're trying to allow them to stop impinging on the retrodiscal tissue. These patients go to physical therapy as well to try to rehabilitate the joint, rehabilitate the range of motion. And once we get the patient pain-free, and once we get them to eliminate their locking and to be able to open with a normal range of motion, we then re-diagnose the case. And you can notice here that this patient is now posturing anteriorly.
Dr. Moshiri, so sorry, your screen is not shared with us.
Thank you so much. Let's see here. I appreciate you saying that.
And also, it seems like when you have your clean check video running, then we get a lot of lag in the voice. So is it possible to show the clean check and then talk over basically after it's or before? Because two together, it seems like it's not working at all.
Absolutely. I tried to, if I could, I tried to close out some programs to see if that helped in the background. So if you would allow me, I want to do that one more time in terms of trying to do it. And if it doesn't work, then I'll take your recommendation and do it that way. Does that sound good?
Thank you so much. Great.
Okay, thank you. Okay. Can you see my presentation now?
Yes.
Did you want me to start over on this case? I'm not sure.
Yes, please. Yes, please.
So this was the let me get out of this. For some reason, this isn't pulling up now. I'm really sorry. We're having a lot of technical difficulties with this talk.
No worries, it happens. Our new world.
Let's see here. This is playing up against me one moment here. Are there any questions I can take at the moment while this is pulling up? I wasn't sure if we could at least take some questions at the moment or not.
There was one question about your consideration with power ridges. One of the someone in the audience didn't quite understand your consideration with power ridges, and someone else was asking about what type of intraoral scanner do you use?
I have an iTero intraoral scanner. It's the newest Element 2. They just came out with the 5D, so I haven't really learned about that or if that's worthwhile to invest in, but I have the newer Element. And then with regards to torque and power ridges, what I was mentioning is that for patients that have power ridges on all 4 upper incisors, that's a situation that I have not had much success in. So I tend to remove the power ridge in that instance, and at least to put attachments on the laterals to help snap the train. And if it's so like a class 2 div 2 as well, I would do the same thing. I'd put attachments in the laterals to torque the centrals. So I at least have attachments on adjacent teeth. If the torque is extreme and I have a lot of root tip, I will just place horizontal beveled attachments on the teeth, because I haven't had really a success of attachments of the tray staying seated, I should say. So that is the consideration. It changes based on the circumstance. So it's not like a one-to-one situation that I always do this or I always do that. It's very circumstantial, but generally speaking, I can tell you if I have all 4 incisors retroclined and I need to procline them, I will not have power ridges on those teeth. I'd rather have at least 2 attachments for retention, because the tray really tends to slip off. I want to make sure, can we see the screen here for me?
It's not shared. I guess it's shared. No, it's shared.
Now we're good? Okay.
Yeah, I've had similar experiences with the power ridges, Mars, where they don't seem to work very well, and I've had this conversation with John Morton, and the beveled horizontal beveled attachments really close to the incisal edges seem to work really, for me at least, they seem to work a lot better for torque.
I agree 100%. And did John tell you though that the horizontal beveled attachment, because he's told me this historically, is that the horizontal beveled attachment does work as well as a power ridge.
That's what he told me too, because I told him I've been using those horizontal bevel attachments, and I just stopped using the power ridges because they just drove me crazy with creating problems that were never there in the beginning, because the teeth intrude the teeth intrude uncontrollably while the power ridges are working, and it's hard to predict how much they're going to escape from the plastic. And I told him I started using these beveled attachments and placing them close to the incisal edge, and he told me exactly what you said. Is that was the initial goal, was they were using them for a while. That when they were developing something for power ridges, that's actually what they developed to start with, and they're supposed to work just as well, but they were trying to avoid attachments on the front teeth.
Yeah, it was an aesthetic solution.
Yeah.
So it unfortunately lost the effective solution, which is what you're stating. So I tend to agree with what you're saying, that my preference, if it's like a mild case, power ridges are okay. I do fine with them, but once I get to moderate to severe, I tend to abandon ship on them. So I appreciate your feedback. So this was the case I was referring to, and I apologize again for the technical difficulties. We should be back up and running here, where this patient, again, is pointing to her jaw joints and was a TM joint patient, as I mentioned. And with regards to the splint here, I'm going to show you a picture of it upcoming. So this is the splint that we use for our joint patients. That, again, is called a pivot splint, worn 24/7, including eating, combined with physical medicine. That's the patient post-splint therapy. So you can kind of see why I don't want to jump into her mouth with Invisalign day 1, is because the splint also helps me to diagnose the bite. This acquired position that she has, we would maybe call a neuromuscular occlusion, is an acquired bite for her. And she's posturing anteriorly to get away from her pain that she previously had. She's probably going back onto her disc a little bit. But I need to now capture her bite here to keep her asymptomatic. She's no longer locking. She has normal range of motion. So how do we do that? And I proposed surgery to her that was not of interest to her at the time. And she already had braces and headgear for 5 years, so she didn't want braces again. So we went ahead and placed her into Invisalign. And we're going to go ahead here and try to intrude the 7 to get auto rotation of the mandible into that more anterior position. Now, I started this conversation with you, if you recall, talking about the transverse dimension and that it can get us into trouble. So if you notice this case, if the mandible is coordinating more anteriorly in this patient, we need to develop the maxilla to expand it. So as we get to the end of this case, we can see here that we got into our class 1 position of the cusp because she started class 2 with no elastics. But look at the upper 6 and 7, you can see the palatal cusp start to dip, buccal cusp start to intrude. Why is that happening? Because there was no attachment on the 7 as it was expanding, plus the tooth is already in buccal version, meaning I really should not have developed this case as much as I had. So that, again, is a consideration. That's what we talked about, buccal root torque to help control it. So in order to compensate for this, we had to help settle the occlusion, wear up and down elastics, and end up dropping the buccal cusp back down again and finishing the patient here. Pre and post for her. This is pre-splint, post-splint, post-Invisalign. 1 year retention for this patient, and then she came back again recently for retainers, so that's 7-year retention. Notice how her attachment improved over time because of the control of the lower incisors from the IPR we did, which is something, again, I really love about digital treatment planning and using aligners, is that I certainly find that the end of my aligner cases that my IMPA is more controlled than I would have with fixed appliances at times, just given, again, the sophistication, I think, of digital treatment planning to be able to see the end in the beginning. So again, talking about expansion and the side effects of it, we can see this patient presents with a posterior crossbite on the right side, some perio issues on the lower anterior. We got clearance from her periodontist and went ahead and started treatment. You can anticipate here that looking at the occlusal, these teeth are already really upright over basal bone, meaning that they're not in buccal version, they're not in lingual version, but they're upright. So I can anticipate that if I'm trying to develop the arch on this case, I'm going to need to add in buccal root torque to try to offset tipping that may occur. Also, as I mentioned, the aligner is not our stiffest wire that we have. It's the least stiff wire we have orthodontically. So sometimes to compensate cases like this, you want to like overexpand a stainless steel wire, let's say clinically, or a TMA wire, whatever the case may be. It's hard to do that with an expanded NiTi, but you want to, again, think about that. So in the development of this case, we're going to go ahead and overtreat the buccal occlusion in terms of the overjet here. So you see there's like a exaggeration of the buccal overjet. And you see I have crossbite elastics built in as well. So you'll see another view of that here. So we're overtreating the buccal overjet and the movement. We're adding buccal root torque in. We have attachments for retention. We're doing everything we can to avoid bite opening. But inevitably, the bite opens. We have crossbite elastics in, we have attachments, we've treated. But that's just a side effect of trying to treat a case like this. So now our goal is, bite opens, we have to close it back down. So I'm going to ask my technician to relapse the case back together again. If you noticed this case because of the perio, I also had a lot of IPR built in. So if I go back to the ClinCheck again, you can see all the IPR that's here. So what is the side effect of IPR clinically, as we mentioned as well, is bite deepening. So you can see in this case, the patient is interfering on the front dentition in addition to the bite opening from splaying. So our posterior open bite is due to 2 issues. And it's always important to diagnose this, because if you don't get a posterior open bite, you haven't done enough cases. It's going to happen to you. And it doesn't mean you made a mistake necessarily. It's a learning experience, but we have to recover from it by diagnosing it properly. So the way to recover from this is that I need to intrude the lower anterior teeth to eliminate the anterior interference. And I need to settle the posterior occlusion back together again to offset the tipping that happened, perhaps by adding in some buccal root torque as well to help lift up the posterior palatal cusps and level the curve of Wilson. So that's where she ends up finishing after we accomplish those movements for her. And let me go back here. I can actually play this ClinCheck for you so you can see that. So this is settling the occlusion again, eliminating the anterior interference, and leveling the posterior curve of Wilson. So that's pre and post for her. Now, my preference is, if I can, I want to try to avoid that type of a movement in terms of settling the occlusion that opened up that way. So how do I approach these cases? Do I treat them with aligners only, or is there a better way potentially? And I would argue that I believe that there's a better way, because again, without this force system built in, and even if you try it, you're still going to get some type of tipping, as I just showed you. When we talked about, by the way, Invisalign First, and attachments are built in, it's not an Invisalign First case, but Invisalign First does give you these type of attachments, which are the retentive attachments to help keep things seated. This is a G5 and G7 attachment that you get from Invisalign. Basically, they're retentive attachments. So if you have a lot of arch development, you want optimized attachments, you can tell your technician, please give me optimized retention attachments on all the posterior dentition. If you're getting a lot of arch development, and that can help to seat the buccal cusp, because you have the surface to push on now, push down to make sure that you can keep the buccal cusp seated. What about this patient? Is this a good case to try to develop with Invisalign? And I think this is an important consideration, because when you look at her and we evaluate her occlusion, we can see from her maxillary occlusal photo that she has teeth that are actually in lingual version. So sometimes I get the question too, well, how much can you expand with Invisalign? It's like asking me, how much do you overtreat with Invisalign? Again, it depends on the patient. Because this patient could probably have a lot of nice arch development because the teeth are tilted to the lingual. So as you look at her case here, in her clean check, you can see that we're performing a lot of arch development. We have attachments on the lower curve, on the lower arch to level the curve of Spee. Bite jump at the end, demonstrating arch coordination. And she gets to here after the first clean check. So getting nice arch development. The bite's not opening very much. Why isn't the bite opening? Because the teeth were in the lingual version. So remember, if the teeth are tilted lingually, as they're extruding, moving to the buccal, they're actually extruding because they're tilted lingually. But as soon as you're upright and starts to go buccal, things start to intrude. So based on where you are, your occlusion can stay together. She happened to ask me at this point, because she was thrilled with her outcome, and I probably should have stopped here. My dad told me, or still tells me, leave well enough alone, meaning that sometimes I stick at things too much. And I probably should have stopped her, but she wanted more arch development because her smile was getting wide and she loved and she was getting compliments on it. So we went ahead and did a refinement. And I started to develop the arches more for her posteriorly, especially in the area of the upper sixes. And that was probably a mistake. I should have done that. And at that point, of course, she was a little bit tired of her attachments. And I was like, yeah, we can try to maybe do it a little bit more. And what's happening here is that now her bites are open in one area. So you can see that she was better off where she was. So again, just know your limits of expansion, because everyone has different biological limits of what's possible. And overall, though, regardless, she was very happy with her outcome, her smile. I asked you before, is there a better way for expansion, especially maybe in these crossbite cases? You have cases that come to you that patients want Invisalign. They may have bilateral posterior crossbites. They may not want surgery, which probably is indicated for them, but for various reasons, they may say no. And I love to use what are called removable Schwartz plates. And I'll show you an example of that. And we use that a lot in our phase 1 cases. We use a lot of removable expanders. We believe in them quite a bit. So this gentleman came in and he wanted to have Invisalign. He was told by multiple orthodontists that he could not have Invisalign or he needed jaw surgery only. And not to disparage anybody, I would agree with regards to the jaw surgery aspect of things, but I think this gentleman could have at least improvement with Invisalign, and why not at least offer improvement to him? So as we go through here and look at the case, again, ortho surgery offered is ideal, but he did not wish to have it. He does present with a bilateral posterior crossbite and open bite, so we're going to address that with dental compensation, namely by using a removable expander as a phase 1 and then transitioning into Invisalign. I love these expanders. The reason why I love them, and you notice that on the picture, it's full coverage on the occlusal, is that on a vertical type case where someone's hyperdivergent, it controls the vertical from opening up too much. So that level of control, I think, is important. But also, it really helps to prevent the palatal cusp from tipping too much because the patient is biting on the expander. There's an intrusive force back there. So you tend to get less tipping of the posterior occlusion during the compensation phase of where you're trying to get everything to come together. Now, obviously, in an adult patient, we're not getting expansion in this situation. We're really getting more of a dentoalveolar change, or what I may call alveolar bending. So you're getting a changing or remodeling of the alveolus. So if we look at this gentleman's palatal vault, I think you can certainly see that there was remodeling of the alveolus. Again, not a sutural change. In our opinion here, I think that's a favorable change for his tongue posture, which is probably resulting in some of his etiology with regards to his open bite. So we send the patients to a speech therapist once they transition off the expander, excuse me. And now if you look at the buccal occlusion, you can see his crossbite is corrected, but the occlusion hasn't tipped severely. And now I can actually bring things back together again with Invisalign and use what I like to call controlled relapse to detail the case and to control it. So we recapture the records here. And one question before I move on that comes up often is how often does the patient turn the expander? And the answer is 2 to 3 times per week. So they wear it full time, one turn, 2 to 3 times per week. They just take the appliance out to eat only. This is his ClinCheck showing that we are closing the bite with anterior extrusion and posterior intrusion to try to control the vertical. He does have class 3 elastics built in as a triangle. So it's, I think the next slide shows that. It's upper 3, 5 to lower 3, I believe, is the class 3 triangle. You notice we have the attachments in the buccal lingual on the 7s for torque. I also have attachments, and I'll play this time, on the occlusal here of the 7s to build in more of an intrusive force, and those are very effective. When you have open bite tendency patients, adding those occlusal attachments really helps to control the vertical. So that is him after the first set of aligners. We went ahead and modified his lower tray and added the buttons 4 to make it a 3-3-4 elastic to help improve his overbite more during treatment. And he got restorative done on the laterals, and that's where we ended up finishing the case. The Ceph pre and post treatment. Ceph traced pre and post treatment, showing again the primary method of closure here was mainly anterior extrusion for this case. 1 year retention for this gentleman. And this is after he's been wearing so our retention protocol for open bite cases specifically as well. They get Vivera retainers, which we're going to discuss open bites in detail tomorrow, but they were Vivera retainers for 6 months full-time, then to bed lifetime. So these pictures are basically after 6 months of nighttime wear only, and as a result is holding fairly stable. So with that, I wanted to get to class 2 malocclusions. And Mo, were there any questions I needed to answer before we moved on? Hopefully the audio is cooperating better.
It is, Dr. Masheri. Thank you. When you have the slide up, if it's possible at any point to take the slide down when you are talking, that would be great somehow.
It's better as long as the video isn't running at the same time.
Got it. Okay.
There was a question about lingual attachments, whether or not you use any lingual attachments on the anteriors.
I get that question in every single lecture I give. And here's the long and short of it. Lingual attachments, if they're placed by the software, are not very effective because the lingual of the incisors is concave. So you have less prominence of the attachment. So you lose a lot of the effective push surface of what you need. And furthermore, you run into bite interferences a lot. So there's not enough occlusal clearance because a lot of the bites we treat tend to be more deep bite patients. Now, having said that, if that is something that interests you or anyone in the audience, there's a gentleman, orthodontist by the name of Christian Fournier, and he practices in Montreal, Canada, and he is known as the lingual Invisalignist. But what he does is that he freehands all of his attachments on the lingual first because he can give them the proper prominence or stature they need to be effective. So if that's something that interests you, I would recommend that you try to maybe get in touch with Christian. He has lectures online as well. I think even on Invisalign's site, it's Fournier, I believe, with regards to the spelling of his last name. He's a great orthodontist. He's a great thinker. And if, again, that's a path you want to take, I'd recommend looking at that. But I personally do not partake in that endeavor because every time I try it, I get frustrated. So I've just learned to stick to what I think works at the moment, which is the attachments on the labial for me. Why would I get frustrated, by the way? Again, it's because I think the attachments on the lingual, as I mentioned, being more concave, I have less predictable movements overall. So that's really the challenge for me. So when we talk about class 2s, of course, the etiology of a class 2 would relate to genetics, the mandible being trapped, secondary to environmental factors, let's say, early loss of dentition, or maybe even some type of a joint pathology where the mandible drops down back. As it pertains to Invisalign, I would like to discuss, perhaps really focus on number 1 and 2 and 3 here to begin with, and we can maybe discuss TMD pathology a little bit later as we talk about orthosurgery, if any questions come up. But of course, molar rotation, is a big one. And our literature suggests that molar rotation correction is really necessary for about 80% of our class 2 malocclusions. And it's something we may take for granted simply because our brackets, if you put them in the right spot, kind of automatically do that for you. But you want to, of course, manage the anchorage because when you derotate a molar, it opens up space mesially. And how you close that space would affect your class 2 correction, because if you pull the molar forward into the space you created, now you just lost a big benefit of class 2 correction. So managing your anchorage during this molar rotation correction is important. Ricketts proposed a way of visualizing this. If you have a line and you drop from the distal buccal cusp to the mesiolingual cusp, it should bisect the cuspid on the opposite side. If that line visually goes distal to the cuspid, that means your molar is rotated mesial in. I found that a good lesson when I learned about it, but I also found that very difficult to communicate to anybody, especially a technician, with regards to molar rotation correction. So what I ask my technician when I want molar rotation correction is I say, please derotate the molars until the buccal surfaces are parallel with each other bilaterally. Because if the buccal surfaces are parallel, that means that your molars have fully pretty much resolved their rotation. Of course, the majority of our class 2s also need expansion of the maxilla. So during this distal rotation, you're also wanting enough arch coordination to allow for this whole analogy to take place where you want the foot to fit within the shoe. If the shoe's too small, of course, the foot cannot slide forward anteriorly. So just like I gave you a priority list in a system for how I dissect moving through a ClinCheck in terms of how you dissect it, you certainly also want to take the consideration for how you approach class 2 malocclusions, in my opinion, because otherwise the technician is going to throw something at you, but they may miss certain things. So the first thing is always, because again, 80% of your class 2s have it, can you please derotate the molars, mesial buccal out, so hinging around the palatal cusp until the buccal surfaces are parallel bilaterally. Next, after that, the question is, do you anticipate a bite jump? So what does that mean? Let's say I've derotated my molars and I've opened up all this space from the derotation, and I responsibly closed all the space by managing my anchorage properly. But there's still a class 2 and overjet remaining. Well, if the overjet remaining is 2 millimeters, that probably can be addressed with elastics. But how does the ClinCheck show that to you? That's what a bite jump is. So a bite jump is representation essentially of arch coordination. Arch coordination from elastics, arch coordination from growth, arch coordination from orthognathic surgery, or arch coordination from removal of an interference. So let's say, for example, the patient's articulating on their 7s only and they're an open bite, but you intrude the 7 out of the way and now the jaw hinges shut. That also can be a representation of bite jump. So bite jump represents 4 things: arch coordination from elastics, growth, orthosurgery, and removal of an interference. Once your molar correction has been achieved, then it's important to evaluate then if segmental distalization is also needed. Meaning, let's say that you've corrected your molar rotation, but the amount of overjet remaining is 6 millimeters, and it's an adult patient. Well, at that point, you're probably not going to just get that with rubber bands only. You may need some ancillary mechanics. So that could be segmental distalization. You could use a Curie distalizer. You could do an extraction of upper bicuspid. You could do judicious IPR. We're all going to treat differently, but then you have to really anticipate that. When is a bite jump too much? And so then you have to start looking into other things. Segmental distalization is one thing with an aligner that you can do to help to address that. And the other consideration, lastly, is like, let's say you have no overjet. You've ran out of overjet, but you're still class 2 in the buccal occlusion. Why would that be? It's from one of 2 reasons. It's either that you have a 2-size discrepancy, meaning a mandibular excess or a maxillary deficiency that you didn't address, or you did not decompensate the case enough. So many class 2s through time have dental alveolar compensation, which generally speaking, let's say it's a class 2 div 1, these lower incisors start to flare and go forward. Well, now you're trying to correct class 2 and you got these flared incisors, you don't have enough overjet, so you need to upright your incisors to get the coordination. So you have to take those into consideration as well with regards to getting everything to seat properly. So I'm going to show you a ClinCheck here next, and just given the audio problems, I want to discuss what you're looking for here. This is a ClinCheck that's showing you proper rotation, or I should say derotation, hinging around the palatal cusp. The default center of rotation in the ClinCheck software is through the central fossa. And let's say that this is a molar, my hand. If I'm derotating through the central fossa and you hinge like this, the palatal cusp is going to eat up the space you gain. It's very important for the hinge axis of rotation to be through the palatal cusp, because as you hinge, you actually open up a room. You don't eat it up. Versus if it's here, you'll eat up the space. So make sure visually, when you look at ClinChecks, that the technician is changing the center of rotation to hinge through the palatal cusp. That's something you need to request. You can't manually do that. So I always say that in class 2 correction, please hinge the center of rotation through the palatal cusp and derotate the molar mesial buccal out until the buccal surfaces are parallel with each other bilaterally, and then use all the space gained to distalize. So you can see here, hopefully, I'm not sure if you can hear me or not, but that's a lot of class 2 correction just with molar rotation correction. So let's look at some cases treated with molar rotation correction and take into account some of the things we've been discussing. This is a young lady who was treated at St. Louis University. Chief complaint was really to make her smile and she did not like her low anterior crowding. Treatment plan here was to correct the class 2. She was class 1 on the right side. We were going to do that with molar rotation correction and IPR to adjust for crowding overall. And I'm sorry, but when my computer crashed and I had to reset it, I think my ClinCheck files went dead on that. So I have some more examples here, bear with me. But this is this young lady treated at 9.5 months with molar rotation correction and IPR only. And I'm going to show another case just showing you how to do that again. So apologize for the technical glitch, but when we crashed there a second ago, I think it reset the links. So this is another patient, again, similar considerations where IPR will be needed due to flaring of the lower incisors and again, molar rotation correction. As you can see here for this case, she is a class 2 Div 1 that had previous ortho treatment. So she is a relapsed case. She previously had upper bis and a lower right bi. So a little bit of an asymmetric extraction pattern. I'm not sure why it was done that way, but regardless, she was concerned with the lower anterior crowding primarily. Very high angle. So just imagine that vertical control is an important consideration for a case like this. Any other type of case here that comes in walking like this, I really would want to put aligners in their mouth to control the vertical. So she was really an ideal candidate for that. Clinical goals for her again are really vertical control and to address her chief complaint. We do want to, of course, classify the occlusion, and we're going to do that with molar rotation correction and arch coordination as well, incorporating some bite jump, as you'll see here in a moment. So here we're seeing molar rotation correction with expansion. As we discussed, the instructions to the technician are below. And as we look at another view of this, we can see that as the molar fully derotates, it does not address the class 2 100%. So remaining correction is needed with a bite jump. So we're showing arch coordination here at the end with a bite jump to finish the rotation, because the rotation did not do it 100%. So this is where this young lady finishes her treatment. Pre and post showing the molar rotation correction. And again, before and after for her. Pan and Ceph. And then trace Ceph for this patient. Excuse me. When do you use class 2 elastics? It's a nuanced question, and it's one that I want to discuss with you because, as I mentioned, when you derotate the molar, you're opening up space instantly. So how do you control the space closure? Because if you don't run a class 2 elastic day 1, your posterior occlusion, the aligner is closing the space. Your posterior can slip forward. So you want to run elastics day 1 in your class 2 cases. But you don't want to overshoot your target, because the other concern that we always have with aligners is finishing too tight anteriorly. So it's important to be very considerate of your overjet. So if I have a class 2 Div 2 patient that I have no overjet on, do I want to run elastics full-time day 1? The answer is probably no. I'm going to start them nighttime only and wait for my overjet to develop before I start to go to full-time wear. If I'm class 2 Div 1, I'll probably start full-time because I know my target. I know where I need to be, and I'm not going to finish too tight anteriorly because I can see the distance in front of me. So you want to start them day 1, but be considerate of your overjet to not end up too tight anteriorly by not knowing how your overjet's going to finish at the end of the day. So we discussed these 2 items, again, molar rotation and bite jump. What about segmental distalization? So segmental distalization is when the aligner will force itself between the dentition. And essentially, once it gets the terminal tooth, so in this case the 7, about halfway of its total distance, then the 6 starts to go. Once the 6 is halfway its total distance, then the 5, then the 4, then the 3, and then the 2 to 2 is retracted with lingual root torque. For every action, there's an equal opposite reaction. So for that distalization movement, there's a reciprocal mesial force. So you will not get distalization or predictable distalization without the use of class 2 elastics. You have to cancel that mesial force and force the teeth to move distally. Again, the elastics are really one of the primary mechanisms of the distalization. Ideally, you want third molars extracted, and not ideally, I mean, they have to be gone. You're not going to get distalization, there's nowhere to go with third molars there, but you want to take your scan, ideally, if the patient presents with them first, have the wisdom tooth then extracted 2 weeks prior to aligner delivery, because I want that regional acceleratory phenomenon to allow for more predictable movement and distalization of the 7, so that I get more predictable outcomes overall, because the 7, of course, is the rate limiting tooth in that whole cascade of events. I want to make sure that 7 ends up where it's supposed to be. So let's look at a treated case. Young man comes in. He was previously treated by a colleague with a Mara appliance. In Boston, you may say Mara, but in Midwest, they say Mara. I'm not sure how it's pronounced there. We can clarify in the question and comments section. But regardless, this appliance did not work for him because he got these migraines, which I use the Mara all the time, and I think it was unusual for him to go through that. So he wanted to go to Invisalign, and the practitioner at the time wasn't treating with Invisalign, so he came to me. And I said, well, I don't know why you got these migraines, but we can treat this with a lot of rubber bands. But if the rubber bands give you headaches, then we may have to just settle for straight teeth that don't necessarily coordinate. And he was on board with that. Thankfully, he did not have any issues, of course, with the elastics. As we go through here, his midline is off to his left by 3 millimeters. And most class 2 subdivisions are usually a mandibular asymmetry. So I think it's important that when you have these asymmetries that you choose to treat with distalization, that you really diagnose to make sure that's the right thing you're doing for the patient, because you don't want to necessarily throw off the midline, the patient's facial midline. So please make sure you consider that before blindly just distalizing to get midlines to match, because I sometimes will see cases come back where there's distalization being used and it's an asymmetric case, and say, well, do you really want to do that? This patient truly needs jaw surgery, or you just may want to have symmetric coordination but just leave the midlines off. No one ever died from a class 2. So you want to maybe look at that and make sure you're doing the right thing. He presents as a class 2 Div 1, and we do have some flared lower incisors, so we do want to take that into consideration. So we have molar rotation correction, segmental distalization, and bite jump. So you can see we're combining the aspects of the list that I've given you, that we did molar rotation correction, we're doing segmental distalization because the amount of discrepancy left after molar rotation was too much. But we also want some bite jump. So why do I want some bite jump here? Well, he's a young man, so what is he going to do? He's going to grow. So on cases that have growth remaining, when you get a ClinCheck back, sometimes the ClinCheck may come back with 80 aligners if you're trying to do distalization. And it's because they're distalizing the class 2 the full way. But it may not be necessary because you're wearing a class 2 elastic. So what is happening, first of all, to the lower dentition? You're getting anchorage loss. Well, how are you reflecting that? That needs to be shown as some level of bite jump just because of the lower anchorage loss. But 2, if the patient's a teenager, you need to show growth because the mandible's coming forward. So always, regardless of whatever is happening, you want to show some level of bite jump in a moderate to severe class 2, either because of the lower arch losing anchorage or because of growth that may be happening if it's a growing patient. This is showing the occlusal, molar rotation correction, and distalization. So you can see that. I would not pay attention to the attachment design on the 7 too much. I was being creative here, just trying to tinker. The most important thing is simply that you have an oblique attachment on it is what's most important. So you're seeing distalization and the jump here. So notice we don't distalize all the way. We're taking into account our growth and our bite jump here. This is at midway through treatment. Molars class 3. So now we're stopping. We're going to stop. We're going to let the case kind of relapse again. So we stopped our elastics at this point, and the patient finished here. So looking at this case overall, pre, mid-treatment, and at the finish, he did not have a refinement. Panel, pre and post-treatment. And his Ceph showing nice lower incisor control. And that's one thing I appreciate about Invisalign a lot, is that I tend to find that my incisor control is more on these class 2 type cases where I'm not flaring the lower incisor as much because we're starting with that rectangular arch wire day 1. Another class 2 case showing molar rotation and bite jump with segmental distalization. This patient, as you notice, is also presenting with a bilateral Brody bite. So the 7s are in complete buccal crossbite. So a challenging type case that if you try to treat this with fixed, that'd be tough, because the patient is probably always going to include on her 7s on the lower arch. To torque those teeth back in is a challenge. I find that these, cases do respond well to Invisalign, but you have to take some considerations, of course. So as we look here at her case, she was primarily, her chief complaint was her flared upper incisors and the spacing that existed. So we're going to reduce her protrusion while fixing the buccal crossbite. And class 2, we're going to do that with molar rotation correction, segmental distalization, bite jump, and using class 2 elastics for anchorage. I'm stopping here just because of the audio difficulty. I'm about to show you a ClinCheck that what I want you to notice, this ClinCheck is showing obviously her first set of aligners. And things were going pretty well, but I had to do a mid-course correction on this case. And the reason being, I want you to pay attention to the upper 6s. The attachment places, the placement and type of attachment of the upper 6s was a vertical attachment that was placed a little bit too far mesially. The teeth were rotating mesial out. So really I should have had the attachment more distal, but it should not have been vertical, it should have been oblique. Her teeth stopped tracking. That's why I needed a mid-course correction, but she was compliant. It was poor attachment design. So please look at that as these molars are derotating, there's a vertical attachment on the 6s, and I should have had an oblique with much more surface area that was better placed in the crown. But you can appreciate in the 7s that we have an attachment to drop the buccal cuts down to move the tooth lingually. We're also intruding the lower 7 out of the way to make room for the upper 7 to come into occlusion. I'll play that one more time so you can see that. So again, intruding the lower 7, bringing the upper 7 in, molar rotation correction, distalization, class 2 correction, and bite jump. Again, we did a mid-course correction here. So this is her at aligner 30, where the upper 6s stopped tracking, but she's making nice progress. So we recapture the case, and we're going to go into refinement. Again, detailing and showing a bite jump for arch coordination. We did some finishing elastics on her, and I'm going to discuss these at the end of the day tomorrow in terms of when and why we decided on finishing elastics. I think it's important, just as a side note here, for your patients to always mention they may need elastics, because your patients essentially in Invisalign, even if they're class 1, they may have posterior open bites. And how are you going to finish that? You may need rubber bands sometimes. So, people don't like to be surprised by things. So I tell all my patients, you're going to need attachments and you're going to need elastics at the end of treatment, just so that they're prepared for it. Some people don't, some people do, and at least they know about it. So be prepared to tell your patients that. So this is where she ends up finishing with her reduced protrusion. And this is pre and post treatment for her. Pre and post here, pano. And Seth showing nice reduction of the protrusion overall. Mo, I wanted to ask you, we've reached 3 o'clock Central Time, but I believe we still have an hour left, correct?
Tiffany, I think we were scheduled from 1 to 4, but I don't have a problem continuing. Tiffany, is that okay?
Yes, I just increased the time on them.
All right, perfect. Yeah, we're good. You can keep going.
Okay, I'm sorry. Just due to the audio difficulty, I think it probably sent me back like 20, 25 minutes
Yep,
and so forth.
absolutely.
Okay, I appreciate that. So again, just showing a class 2 case and demonstrating the mechanics of molar rotation, segmental distalization, and bite jump. If we look at this young lady, you can see that she's missing her upper laterals, and she's also missing her lower centrals. So she had some compensatory drift of the upper dentition into the missing lateral space. So you can imagine that as the dentition tends to drift mesially, which happens in a lot of class 2 cases, that's why they need molar rotation correction, because if someone has a narrow maxilla, which many class 2 patients do, if it's V-shaped, the molar drifts mesially but hinges around the palatal cusp. So you need to derotate it and get it back and drive the dentition backwards. So a lot of, I think what we perceive as distalization is simply taking the teeth and uprighting the crown over the root, which is really tipping. So that is in the wheelhouse of a strength of an aligner, but we just need to make sure it's happening and pay attention to it. So she's full step class 2 molar on the 6s from all this drift that's occurred over time on the right side and almost full step on the left. Our goals of treatment for her here are to go ahead and try to reopen space and get implant replacement when she's of age. So we're going to perform again class 2 correction with molar rotation, bite jump, and distalization. The ClinCheck I'm showing again, just talking through it because I want to make sure you hear me properly. Please again notice, and I'm not one to just show you successes. I like to show mistakes because I hopefully feel like that's teaching you something more than me just showing you things that worked. On the upper arch, again, she had poor attachment design for the molars. The G7 attachments that exist currently for distal molar rotation are at an oblique. When you're derotating teeth or when you're doing distalization, you want an attachment at an oblique. I'm going to use my bottle here because as I'm distalizing, I have a surface to push on to push that tooth distally, but I have a surface to push down on to keep the tooth seated during the distal movement. So here we have vertical attachments, and again, you're going to see the consequence of that. And we're opening space, of course, for the missing laterals. So distalization and opening room for the missing lateral incisors. So here you see the progress, and here you see the failure on the right buccal occlusion. And again, she's articulating on the 4, meaning that this is not a posterior open bite from heavy anterior interferences. This is a posterior open bite from lack of teeth tracking in the aligner. So we have to recapture the case, do a refinement, and now add attachments to try to bring the buccal occlusion together. So we just take a progress pano to see how we're doing on the space opening, dial in any compensations needed in the ClinCheck, keep going, and seat the occlusion. So this is her after her refinement. We retained her with resin bonded bridges, which is our retainer of choice in cases like this, simply because, first of all, obviously from a practical standpoint, the patient's not taking the retainer out when they eat, but also helps to prevent convergence of the roots into the edentulous site over time, which can happen with flippers, which was, I think, a more, I don't want to say antiquated, but I think maybe more readily accepted historically way of doing things. But I've found a lot of relapse with flippers, so we tend to use these resin bonded bridges instead. Pre and post treatment for this patient, Ceph-wise. And again, pictures. What I hope to show you here is kind of an evolution of attachment design so you can see what does not work and what does work. So young man comes in, class 2 div 1 subdivision right, maxillary midline again off to the left. So it is appropriate to use distalization of the right buccal segment to correct his class 2 malocclusion and his deep bite. So again, treatment plan, class 2 correction with Invisalign. We're using molar rotation, bite jump, and distalization. Now you can see I have attachments at an oblique, and now we are having a push surface for the liner to engage to get the proper forces needed for not only distalization, but also retention. The canine being high cuspid, we have our elastic going as a class 2 from the canine to the lower molar to get intrusive force on that cuspid to also bring it down, hopefully to keep tracking. Regardless of my efforts, we did have a little bit of tracking issues with the cuspid. So when we get to the end of this first set of the liners after 1 year, you can see we're making very nice progress on the class 2, but I need to help drop the canine down more. So we focus on that in refinement and then finish the case up here. Pre and post treatment for him. Seth pre and post as well. And his picture is showing again his outcomes. Along the same trend of a class 2 div 2 deep bite adult male. Again, our goals here for him were to correct the class 2 malocclusion, but you can see how upright his lower incisors are, and he has a Bolton discrepancy. So this is a case begging for proclination. I'm not going to address this gentleman's Bolton discrepancy with IPR. And I think diagnosis is very key to long-term success. So we told him day one, I can't treat you with Invisalign, and I don't want to, or even braces for that matter, it really doesn't matter, without opening up space for restorative. So the goals are here to use our mechanics to get not only distalization, and again, I wish that attachment on the 6 was an oblique attachment if I had to do it over again, but for whatever reason, his sat pretty well. And we're getting, again, distalization and space opening anteriorly to get a better interincisal angle. I want to show you this one more time because there's an important, I'm going to jump out of this just in case you're not hearing me. There's an important thing to watch in spin check is that as you're distalizing, they're extruding. And that's something I had to do because normally your technician is going to distalize the teeth along the plane of occlusion to avoid heavy contact because that's what they're trained to do. But on a deep bite adult male, I want heavy contact posteriorly to open the vertical. So as these teeth are distalizing, they're going to extrude. So please notice the teeth are extruding during distalization, and we have heavy posterior contact. So there's overlap of the teeth. So as you saw there's almost like overlap of the teeth at the end of the clinch check. Here, again, we see the outcome of forcing heavy contact using the power of proclination. This is the gentleman after one set of liners. He did not need a refinement. We went ahead and sent him out for his restorative, and that's him then fully restored. Pre and post treatment for him. Adult female, again, class 2 considerations, class 2 div 2, and again, I'm showing this as a teaching case. I like the attachments on this case, but I don't like the staging. And let's get into that. The default staging for Invisalign during distalization is that you get the molars distalizing, and then once they're pretty much about 1/2 to 2/3 of their distance, then the front teeth start to move. Well, could you imagine why the patient is there to see you? They're probably there to see you at some level because of this, right? So what I've learned is what you need to ask for over time is that you want segmental distalization with an aesthetic start. And if you do not ask for an aesthetic start, your front teeth will not move until middle of treatment. And that really doesn't make much sense. So if you look here, we have distalization, but front teeth aren't moving, okay? So that was not ideal for this patient. So finally, around month number 6 or 7, the front teeth start to move. So that was a miss on my end. But the mechanics are sound otherwise. And we can see here that she proceeds through a lot of trays because of the overtreatment. The last 10 are passive trays. So about 1.5 years of treatment overall. Trays are great. She's a good patient. And that's where she finishes after her service. She's not in refinement. So again, if I had that aesthetic start, I think I would have done a better service. So definitely you want to ask for that to happen. If you look at the next picture coming up here, what I want to show you is the push surface of the G7 attachments, how nice they are. So when I have distalization now, I ask for the G7 distal molar rotation attachments, because those give me the push surfaces to engage to not only get the distal movement, but also, again, keep the aligner sat properly during treatment. There was a question here, I'm not sure who it was from, but regardless, I was saying, could we share your slides, perhaps, so we can offer that at the end? And let me work on it, but the answer is yes. I'm happy to share the slides with you, especially given the technical difficulties. I want to make sure that you're getting the maximum learning experience. I'm happy to do that. Of course, it would be as a PDF file, but I'm happy to share the presentation for your learning. And again, I'm happy to take questions as well as we kind of get through this. But
thank you, Dr. Nasheri.
I've got some questions here that people sent in. There was a question about the split design that you use, and a question about when you expand with a Schwartz and when you expand with the liners. Those are the two from the end of the previous lecture. Then we have a few more related to this one.
The split design, I'm assuming, is for the molar attachment. I think that's what that's referencing.
I think they were talking about you used an occlusal split.
Oh, pardon me. The splint design.
Yeah.
The splint design. So that lower splint is used for patients that have internal joint derangement. So if somebody has clicking, popping, or locking, and with pain, of course, if they just click and they have no pain, we don't give them a splint first, but I tell them two things. There's two considerations. One, if you develop TM joint symptoms during treatment, then I need to stop treatment and put you into splint therapy, and then we can resume Invisalign as a separate phase of treatment, meaning there's an additional cost. So we tell them that up front. But if TM joint issues arise during treatment, so someone has a history of a click, let's say, and let's say that patient is a deep bite, okay? Let's say it's just 4 millimeters of overbite, not significant, but they have a history of clicking, and you put an aligner in their mouth. Some patients may do better in a situation like that. Some do worse. Why do some people do worse? It's my hypothesis that if the patient is a clencher and you put 2 layers of plastic between their teeth, you're now violating their overjet. So they're clenching and the 2 layers of plastic are pushing their jaw back and loading their joint. And so it actually pushes the rock over the hill and it makes them worse. So in those instances, what we do, and it kind of relates to the splint question, is I cut the aligner off of the 7s and I flow band lock on the occlusal of the 7s to open up the joint space. So the splint design we use is meant to open up the joint space and allow that joint to heal. It's distracting the joint space open. And then we send them to physical therapy. So we only use lower splints in internal joint derangement cases. If I have a myofascial muscular issue, no joint problems per se, but the patient is just kind of hot on their musculature, I give them a flat plane occlusal splint, try to deprogram them, break the cycle of clenching, send them to PT, send them to a massage therapist, maybe give them some clonazepam or Flexerol, something to break the cycle of clenching. And once I get them to relax, then transition them into aligners. So the majority of splints we use, I'd say without exaggeration, 99% are the lower pivot splints that I showed. And then Mo, I'm sorry, what was the second question? I apologize.
I think regarding that pivot splint, they wanted to know kind of what it looked like, if you could describe that lower pivot splint again. I think that was the question.
Okay, let me pull up a picture of it.
And the other one was related to when you use that Schwartz expander, that removable plate expander, versus expanding with the aligners.
Thank you. So while I'm waiting for my presentation to catch up to me here, let me discuss at least the Schwartz plate. So the Schwartz appliance I will primarily use on anyone I can, meaning that if a patient walks in with a posterior crossbite, an adult patient, my preference is to use that Schwartz plate because of the control I showed you, meaning that that Schwartz plate limits a lot of the tipping that you would otherwise get in the aligner. So I will use that Schwartz plate as really my preference. I do it low, I do it slow, I do it controlled, and I get great outcomes with it. When do I use Invisalign only? When the patient tells me they're not going to wear the Schwartz plate. So, and that's just an honest answer, because some people are like, well, you know, I'm a public speaker. I can't put that thing in my mouth and, you know, deal with that. And, you know, and I tell them, well, you know, I get that. I can understand where you're coming from, but that may lead to longer treatment time, because the side effect of that of tipping with the aligner usually requires, in my opinion, more recovery in terms of refinements than it does from what I'm trying to do in terms of the controlled relapse from the Schwartz plate. So I hope that makes sense. Sorry, I'm looking for that splint picture, and I think.
So I can ask you another couple of questions we've got while you're looking for that. There was a question about, do you use twin attachments to correct molar tip? The buccal and lingual tip attachments, buccal and lingual twin attachments. Do you ever use those for molar tip, was the question.
Sometimes, a twin attachment, if you think about it, is kind of the same thing as a 5mm vertical. It's just kind of cut down the middle. So I tinker with things. I do them sometimes just because I'm curious, but sometimes I find that it's more effort because I have to tell the technician, give me a twin attachment, and then they give me the two attachments, and then I have to customize them in terms of, you know, getting them to where they need to be. So it just depends on how much coffee I've had that day is the answer to the question, but it's the same as a 5mm horizontal, so I'll use one or the other.
And do you rescan after your sequential distalization to account for the bite jump?
No, the bite jump is part of that. So let me clarify. I sometimes will show the sequential distalization mechanics, and I have colleagues, for example, say, Maz, I asked what you showed, and I got like 90 aligners. And I tell them the reason why you got 90 aligners is because you didn't ask for a portion of that to be shown as a bite jump. Because when you're wearing a class 2 elastic, what is correcting the class 2 is not only the maxilla, it's also the mandible, because you're either getting anchorage loss by dental alveolar mesial movement of the lower dentition, or if it's a teenager, you could account for some growth. So in an adult patient, I'll tell my technician, give me 75% distalization, 25% bite jump for the total correction. But in a kid, I may say, I want only 50% distalization and 50% bite jump, because I'm going to take into account that that kid's going to grow on me. So there's no need to rescan. It's just a matter of being efficient with not printing too many aligners, because you won't need that many, because you're going to be getting your class 2 correction on the opposite jaw as well. Mo, do you see the splint here?
No, I don't see your screen right now.
Let me, I have it pulled up, so I want to make sure if you all are seeing it or not. Let me see. How about now?
I think it's loading.
You can see okay. So this is the pivot splint. It is made in house. So I have a lab technician that we've had one for 30 years. I'm on my since I've been there, my fourth one. But she's great, and regardless, we train every single one to make this. It's a Gelb type splint. You can see there's that wire behind the linguals just to reinforce it because the patient has to eat with it to make it strong. It's pretty much flat. It's about 3 millimeters in thickness from the 4 to the 7. And we do not have an opposing dentition or an articulator when you make this. You just fabricate it, you make it flat. There's ball clasp, as you can see, for retention, so you can tighten it so the patient is comfortable eating with it because the patient does eat with this in. And when you put it in the patient's mouth, you adjust it so they hit on the mesial palatal cusp of the upper 7s or 6s bilaterally, whichever doesn't prop them open too much. But ideally, you'd like to be on the 7s because you want to try to get behind the masseter in terms of the fulcrum to actually hinge the condyle out of the fossa. That's the hypothesis behind this, is that we're trying to increase the joint space. And then you see the patient monthly to continue to adjust them, because normally as their muscles relax, they're going to reposture on the splint. So you need to adjust them so they continue to hit 1 point each side. So that is that splint.
Thank you.
My pleasure.
I think there's also a question about do you ever distalize 6s and 7s first, then distalize the premolars?
So I will tell you that there is a doctor that works with Invisalign by the name of Mina. I can't remember her last name, unfortunately, but regardless, one of the interesting things about Invisalign and just the whole concept of Invisalign and their ecosystem is that Invisalign is scanning, and you're scanning your patients for refinement, for finishes, for Vivera, whatever the case may be. And what are you sending them? You're sending them data, and that gives the advantage of studying that. And so she told me essentially that when you do distalization, in her experience, because you have doctors that do things differently all over the country, all over the world. Now, there's some doctors that will do the 6 and 7 simultaneously. There's others that do the 7, the 6, the 5, the 4 by itself, like I do. And from what they saw from the data harvesting they did, they saw no difference between the two. So I personally haven't tried it yet, to be honest. But according to their research and data, they're saying it's just as effective. So that's my honest answer. No, I have not attempted it. Any other questions, Mo?
I think that's it. I think there was a question that I didn't completely understand. I'll just read it the way it is.
Sure.
How to assess if you need molar distalization by the sagittal position on the ceph?
So, it's interesting. I don't look at my ceph so much for distalization as I do my pano. And clearly, how you address your class 2. Now, how many people actually have maxillary procumbency, where that's the nature of their class 2? Some people indeed may, but assuming let's say it's an adult patient, usually you're compensating for mandibular deficiency. So I'm not necessarily looking at my ceph to see how much I'm going to distalize, and I'm looking for, do I have real estate to distalize into? Because if I look at my pano and I don't have much of a tuberosity or room to go, or if the teeth are already tilted distally, I'm not really going to get anywhere very quickly. And maybe you could see the distal tip on your ceph as well, but that's really the considerations I pretty much have for that, is do I have enough tuberosity or bone to move into for distalization even be an option at that point?
Thank you. I think that's the last of the questions that I've. Let's see if there's anything new. Yeah, there are a couple of new ones. Yeah, there are a couple of new ones. Could you please talk about the advantage of G7 attachments over oblique attachments that you designed by yourself on the 6s? Which one do you prefer for distalization?
So in my opinion, nowadays, contemporary, I think, management of class 2s, I prefer the G7s. They weren't around until a couple of years ago. And the reason why I prefer them is that, as I showed, the push surface is truly where you need it to be. And generally, those optimized attachments have activations to help the retention of the tooth in the aligner. So it's important that you learn to leverage enhancements in the software because it reduces your doctor time. The advantage of Invisalign is once the lenses are printed, it's very clinically efficient. The disadvantage of Invisalign is that it requires more doctor time to bend the aligner. So you want to try to leverage, I think, enhancements that work versus when you need to jump in and intercede. And for that question, the G7s are fantastic for distalization, so I do prefer them.
And what do you do when the bite jump they give you is unreal?
Is what, I'm sorry?
I guess if it's not realistic, if they give you a bite jump that's not realistic.
Yeah, you just tell them to reduce, I mean, you just give them guidance. You have to give them guidance. Say, this is excessive, please give me more distalization, or this is not enough, please give me more. It's something that you can change. So you have to customize it to what you believe is realistic.
The last one I've got here is, do you feel Vivera retainers are strong enough to hold the expansion, or do you feel like you need to alternate between a Vivera and a Holly retainer?
I have retained my orthognathic cases that have had skeletal expansion with Viveras with great success. My oral surgeon is doing a post-expansion study right now to see that and how it is. I think in my experience, you know, I've used Viveras and I haven't had an issue of transverse. So basically, to answer the question, I believe the Viveras are stiff enough to hold the transverse. I've not had a problem with it. When I started using Invisalign, 12 years ago, I was using Hawleys because I was so concerned about it. But even these people that have the 3-ways that I showed you, the Schwartz plate, the open bite gentleman, 1 year after, he was holding just fine. I have another one I'll show you tomorrow that I used a 3-way on, the Schwartz plate, 5 years post retention, that he had a Vivera and he's holding beautifully as well. So I have the faith in the stiffness of the Vivera to maintain that.
Thanks, Maz. Maz, I'm going to have to step away from him for a little bit, and I'm going to ask Negin Katebi to take over for me while I'm gone. But you can keep going.
Thank you very much. I appreciate it. Thanks for people still hanging in there. We're almost done here. I'd say we have about 5 cases left, and then we'll finish up this session. So, we talked about biomechanics. We talked about class 2s. Now I want to talk about class 3s. The gentleman, the reason why he's pointing, if you guys are wondering, by the way, if anyone has joint pathology, we always ask him to point to it at the time of initial exam so we can document it properly. So that's why he's doing that. He has clicking of his joints and pain of his left masseter, but he did not have pain in his jaw joint. And we believe a lot of this was due to his occlusion, obviously. So we did not necessarily treat him with a splint. We thought we could manage this with Invisalign and physical therapy. So at this point for this gentleman, the considerations for class 3s are really as follows. One, you of course always want to see if there's a CR-CO discrepancy. This gentleman, that was indeed his CR and CO, were concentric. So when we go back here, I could not shift his mandible distally. So that's where he was. And with regards to ClinCheck design, what we're going to do for this gentleman, and I apologize again, because when my computer crashed, I know the link for this case is not here. He had turbos that I placed in the software on the lingual of the lower 2 to 2. So what I'm getting at is this. You can request from Invisalign, say I want precision bite ramps, which are Invisalign's turbos, on the lingual of the upper incisors. But you cannot request turbos on the lingual of the lower, but you can certainly add them, meaning you can put conventional horizontal attachments on the lingual of the lower incisors, and you can even stack them. So you can put one on top of the other, make them as thick as you want. and they are not filled. They are simply there because now when this deep bite class 3 patient bites down, he's going to hit that turbo and it's going to prop him open. And as he's propped open, the class 3 elastics now are going to be more effective. So for this gentleman, then we can jump his bite to here and then go into a refinement and finish his case to here. So really, again, class 3 mechanics, if the patient is a deep bite, I think one consideration to take is to use a lingual bite turbo on the lower 2-2. Some other things to discuss with class 3s are that, you know, you can do segmental distalization with a patient that presents to you as a class 3, but again, we're doing orthodontics with Invisalign. We're not just doing Invisalign. So what would be the difference of distalizing in the mandible segmentally, let's say, versus distalizing in the maxilla? And the difference primarily that I want you to think about versus obviously anatomy is a consideration, but quality of bone, because the bone in the posterior mandible is much more dense than it is in the posterior maxilla. So you're not going to get the same response to tooth movement as what the cartoon is going to show you. So we need to take that into consideration. So I generally will not try segmental distalization in the mandible. I need heavier mechanics. So if the case is outside of the means of just simple arch coordination, where I can just wear rubber bands to coordinate arches, I will incorporate retromolar tabs for class 3 mandibular issues. So looking at this gentleman, class 3 malocclusion, left posterior crossbite, narrow maxilla, you know, previous, he had a hockey accident when he was a kiddo. And I said, sir, you need jaw surgery if I'm going to really give you a nice result here. And his wife is a general surgeon. And she said, nope, not going to do it. So I had to get creative and figure out how we're going to do this with just tooth movement. So I'm going to show you a ClinCheck here that is showing the setup of how the distalization is occurring. And I want to talk through it again to make sure there's no audio issues. Is what the ClinCheck is going to show you is where the TADs are placed, and that we have an elastic that goes from the TAD to the aligner, which is a 6-ounce heavy elastic. And then we also have an elastic from the upper 7 to the lower 3. So it's an inner arch elastic to help really distalize the lower dentition, perhaps even get a little bit of mesial movement of the upper dentition due to the interarch elastic being used. So this is a representation of the ClinCheck that's coming up here in a moment. Those are the TADs that are being placed in the retromolar area. Those are Chris Chang's TADs. So they're, I think, called ortho bone screw, 12 millimeter stainless steel TADs. And the mechanics again, from the TAD to the aligner, and then the interarch elastics being used as well. That's a lot of bite jump. That's a lot of arch coordination, and that's representing again the en masse distal movement I'm expecting to get from the use of the elastics. This is him after his first set of aligners. He had 17 aligners in the first set, and he actually wore them weekly, so that's really not more than about 4 months worth of movement. He did not need a lot of leveling and aligning. So that's a lot of arch coordination for that period of time. However, we're going to go to refinement. Same exact mechanics, so nothing interesting really to show in the ClinCheck. So after refinement, he looks like this, and then we get him restored with implants on the lower anterior teeth, and that's where he ends up finishing. I did leave the button on there for the class 3 elastics to be worn during retention for a period of time, although really I'm not sure if it was necessary because obviously he had an implant placed in the lower, but it was just a lot of correction. So I wanted to make sure that we didn't lose any ground there, and we did not, and I ended up removing the button, I think, after a couple months. Again, same mechanics, high angle class 3 case. Again, a gentleman that I'm telling him, you know, sir, you need jaw surgery for an ideal result. I think obviously versus the previous guy, this guy could really benefit from it aesthetically, but he was not interested in that. So we're going to do our best with the mechanics I just showed you, which are Invisalign, retromolar TADs, and en masse distalization of the mandibular dentition. So ClinCheck here showing a lot of IPR, and this is just a screenshot. So hopefully, I'm assuming you can hear me, but a lot of IPR here. And this is obviously going to benefit the class 3, but look at his Bolton, 5.3 millimeters. So that is something I want to know. That's something that's really going to help me in this case. And I can honestly tell you, I'm not sure how the residents treatment plan their cases at Harvard, but I don't run a Bolton analysis in every single fixed appliance case I do. And I'm just being honest. It's invaluable information, and it's information that's so easy to get with digital treatment planning. So that's really an advantage that I find with clear aligners, that I'm able to do that. Here we have the ClinCheck again, showing a little bit of actual mesial movement, so segmental mesialization, which is another consideration of class 3 correction, and bite jump. So again, I want to talk through that ClinCheck for you. We're getting segmental mesialization, lower distalization, IPR, and notice we're leaving a little bit of spaces blowing up for restorative, trying to intrude posterior out of the way to help control his vertical. So again, let that play through. This is some progress, so making nice changes here. You can see the plate that we're using in this case. You know, we've tinkered around with what we like. Sometimes we use electric molars. If there's not enough room in the ramus, we may use these skeletal anchor plates and the buccal occlusion. Just depends on the patient, what we see on the CBCT, and what room we have to run. See the patient with his trays in. Again, kind of the mechanics being used overall. And that's where he ended up finishing at the end of treatment. Pre and post for him. Last class 3 case, I believe. So again, orthodontic surgery ideally, but you know, the gentleman has a mustache because I think he understands that he is mid-face deficient to an extent. But we're going to go ahead here and treatment plan this the same exact way, just showing you the mechanics again. Retromolar TADs to be used, along with aligners to help control his high angle class 3 tendency. So 6 ounce to the tray, 1/4 4 ounce inter-arch, bite jump showing the arch coordination. This is him at the end of the first set of aligners. You can see here, he now has a posterior open bite versus an anterior open bite. And why is that? If you recall when he started, and I'll jump back here so you can see, he started off with a lot of spacing between his front teeth. And so we were closing that space in the ClinCheck. What happens when you close spaces orthodontically? Bite deepens. So we ended up, in this case, too tight anteriorly, plus we had some IPR to boot. So the bite was a little bit too tight from, first of all, not enough class 3 correction, but second of all, the curve of speed was not flattened all the way. So in refinement, what you're going to notice here is that we're going to eliminate the interference to close the posterior open bite, which is representing arch coordination and also removal of the interference. So arch coordination from class 3 elastics, and then also removal of the interference. So this is his progress and his ClinCheck. Instructions to the technician as to what needs to be done. So again, removal of anterior interferences, continuing class 3 mechanics, and arch coordination to finish the jump. So that's this gentleman when he's all said and done. Pre and post treatment. showing some distalization on the right side and a little bit of an asymmetry, so more distalization on the right versus the left. Ceph pre and post treatment, and his tracing showing what happened here. So again, some mesialization of the maxillary position, uprighting distalization of the lower, and overall closing the bite with some anterior extrusion as well. So tips for class 3 cases. Again, mandibular bone is more dense, so do you need heavier mechanics? What's the inclination of the molars? If the molars are mesially inclined, it's probably more favorable in terms of the distalization mechanics being used. Would mesialization of the maxillary dentition be applicable? Meaning, can you use segmental mesialization? Because teeth and maxilla tend to move pretty readily. And I think that the aligners are really good at doing that. Use your TSD, meaning your two size discrepancies to your benefit. If there's a mandibular excess, which many patients have, use that to help detail your class 3. But if IPR is chosen, make sure you understand the bite deepening effects that come along with it. Eliminate your posterior and anterior interferences as you're distalizing, of course. If there's plunging cusp on the 7s, it'll prevent your buccal occlusion from seating. I have this, I haven't really talked about it, I guess. Consider elastics from the lingual of the upper to the buccal of the lower Y. A lot of class 3s have narrow maxillas. A lot of class 3 malocclusions have low tongue posture. So if you're developing the upper arch form, that helps that to occur. So you can do a crossbite class 3, for example, and also consider the bite turbos on the lingual of the lower, as I mentioned, to help prop the bite open. So with that, that was the last slide for today. Tomorrow we're going to go into deep bites, open bites, and orthodontic surgery. Again, I'm very sorry for the technical difficulties. It was outside of my control. We're going to try to nail it down here, I think, after the call and figure out how we can improve that for tomorrow. But if there's any other questions, I'm happy to take them at this time.
Thank you so much, Dr. Mashiri. That was very informative and nice. Honestly, the only one question that was left over from before, it's they were asking how many hours do you recommend to use the Vivera?
So I have my patients to wear the Vivera full-time for 6 months, then to bed lifetime. So full-time for 6 months, then to bed lifetime.
Perfect. Yeah, I don't see any new question. Let me see. Okay, no, there is one more question. They're asking why you put on the screws in retromolar instead of mandibular shelf.
Instead of buccal shelf?
Yes.
It just has to do with the anatomy of the patient. So if the patient has a thin buccal shelf, or if the surgeon isn't comfortable placing in there, I let the surgeon decide, honestly, because he takes a CBCT and he decides where he feels like he has enough bone and clearance, and he will go ahead and place them. And we have such a close working relationship that I trust whatever he sends in, because the mechanics don't change for me. If they're in the retromolar or buccal shelf, they're still attaching that to the slit on the aligner, and then they have the inner arch class 3s as well. So I just let the surgeon decide where he thinks he'll have the most success placing the implant.
Thank you. Do you run your class 3 from lingual of upper 7s to lower 3s, or any side effects that you should be able to see?
Not necessarily. I mean, the one side effect I'll tell you is that, and this is regardless if it's buccal or lingual. If it's buccal or lingual, you know, this guy's molar, if you notice, they're extruded. And I see that a lot in class 3 cases. If you are attaching a button to the molar directly, or even on your aligner, if you have attachments and you're going on an aligner, you can maybe have a tendency to drop that molar down or rotate the occlusal plane a little bit. That's the one consideration I would be careful of, but sometimes that can be favorable in a class 3 case because it rotates the mandible down and back. But if it's a high angle class 3 case, you need to be careful with that, obviously. But that's the one side effect that you could potentially see.
Great. And they're asking if you are using any fixed retainers. Do you use just the Vivera, or there are some cases that you're considering other sort of retention?
I may put one fixed retainer on a year, and that is usually due to mobility concerns if someone has existing periodontal issues, or it's just a very redundant, stubborn diastema, for example. But in most cases, the Vivera is sufficient. I don't have any space opening issues or anything of that nature. Just the Vivera. I mean, most fixed retainers will fail within 5 years, and I think we have a lot of literature that will prove that in our profession. So any patient that has a fix still needs an overlay retainer. So if I'm giving them an overlay anyways, I don't really see the purpose of marrying them with a fixed. That's just my personal philosophy. I know many would disagree with me, and that's totally fine. But that's the reason why we don't use them.
Great. Thank you. I don't see any more new questions coming in.
Excellent. Well, thank you so much for hosting, and I look forward to seeing you guys tomorrow. Okay.
Thank you, Dr. Mashiri.
Thank you.
Thank you, everybody.
Thank you very
for being
much.
with us. And just to let everybody know that it's the same registration link for tomorrow's session. Thank you all.
Thank
Thank
you.
you, Dr. Sherry. Have a good night.
Thank you so much.